All right. Well, good morning, everyone. Thank you for joining for our 2026 Net Patient and Caregiver Symposium. I'm happy to say this is our second event. Our last event was done 2 years ago. And thank you also for joining on a Saturday, not only a Saturday, but also Valentine's Day. So we know the personal things and sacrifices that you have to take. So we appreciate you being here. So with that regard, I was going to go ahead and start with a quick presentation and overview of our conference. So let me go ahead and share my slides. Um, Alana, are you able to give me sharing privileges? Oh,
Be able to
perfect.
share now.
Yep, great. Excellent. Okay. All right. Let me get this in the right mode. All right. And switch this. And you guys see one slide at this point? Okay,
Yes.
perfect.
Perfect. Yes.
Well, again, welcome. I am very pleased to co-host this conference along with Drs. Delphine, Chen, and Iravani. So I am Dr. David Zhen. I'm one of our GI medical oncologists here at the Fred Hutch. I also lead our Neuroendocrine tumor program alongside with Dr. Chen, who's part of our nuclear medicine department and helps with molecular imaging and therapy, which obviously is a very important in neuroendocrine tumors, as well as Dr. Iravani, who's our Theranostics clinical director. And obviously, we're going to run through some cases today discussing about PRRT, radioligand therapy, and some novel trials. And so he leads that part of our group. And so, really, our objectives for leading this conference is really to help educate the community on the diagnosis and management of NETs, which obviously, as we know, is very nuanced and can be very specific. And some providers may not have as much experience out in the community. And so, we want to make sure that we educate our community on how to best treat this cancer. And then we'll talk about standard and evolving treatments for neuroendocrine tumors, and then really highlight kind of the expertise and how we may manage some patients in select situations. And so, just to give a background about our program, we're a fairly young program, although hopefully not as young as I keep saying. But we this originally started back in 2019 when Dr. Chen had joined our group. I had joined a couple of years prior to that. And we were seeing a lot of neuroendocrine patients, but we realized that we didn't really have a central forum to really discuss cases. And so that's where we decided that we would create a multidisciplinary group and tumor board where basically we could unite all of our specialties to really have a discussion of cases. And that includes other medical oncology team, surgical oncology team, nuclear medicine, radiology, endocrinology, and others. And since that period of time, we've had significant growth in terms of our neuroendocrine patient volumes. We've grown our program by about 20-30% per year, and we at least see over 300 patients per year. So we do have quite a bit of experience with neuroendocrine tumors. And this has been very helpful for us, not only just, for our patients, but also for us as we kind of learn from each other and try to improve from our quality of care. And that really is just continue to lead our program in terms of getting, talented faculty, but also developing a research program where, we're able to now bring trials to our group and such. So I want to introduce some of the high-level groups that are kind of critical to our neuroendocrine program. This is not to say this is everyone. Our group is very large, but in terms of one of our larger groups, our GI medical oncology group, we have grown from even a couple of years ago since we last presented. And these are our GI medical oncologists. Dr. Chiorean is the lead of our GI oncology group, and she'll be participating in the second tumor board for today. And then we're also growing with Dr. Sheila Damley, who's one of our actually current hematology oncology fellows, and she'll be starting soon, hopefully in the next couple of months. So, and hopefully we'll maybe even growing the program in the future. And then likewise, we can't do our jobs in treating patients without our nuclear medicine and radiology colleagues, very important for diagnosis and also treatments. Obviously, we've discussed Doctors Chen and Iravani and the nuclear medicine group, but we've also have a couple of other providers, Dr. Castellanos and Dr. Kumar, as well as the very talented technicians such as Zach, and then our nurse practitioners, Mr. Erickson and Ms. Nega, very critical for supporting our kind of radioligand therapy structure. And then also our abdominal imaging. So these are radiologists who reads our scans and able to help us interpret in terms of both the diagnosis and also management of our patients. And then likewise, obviously, surgery, interventional radiology, which we'll kind of review in our tumor boards today. These programs have also grown, and we have talented faculty. So Dr. Childers is here today, so we're blessed to have his presence, and so looking forward to hear his discussion. And then Dr. Laidlaw from Interventional Radiology is here as well. And then we also have other surgeons who, surgeons go by in terms of their expertise, in terms of which organ they operate. And so we have also talented surgeons that, depending on if it's in the abdominal space, such as Doctors Mogul and Sherab. We also have the esophagus and stomach with Dr. Olshager and Dr. Farja. And then our colorectal surgeons, Doctors Crane, Atkinson, and Siddharathan. Now, with that said, even though, neuroendocrine tumors are kind of treated and seen differently at different centers, at our centers, because we see such a large volume of patients, and I'm a GI oncologist, I often see neuroendocrine tumors of the gastrointestinal tract, so pancreas, small intestine, and such. Obviously, I can't ignore the fact that we also see other neuroendocrine tumors, so such as lung, and then also a rare type called pheochromocytoma and paraganglioma. And these are managed also in conjunction with our lung team. So just introduce our lung team here, also our endocrinology colleagues as well too. And then obviously with neuroendocrine patients, not only are we dealing with the tumors, but they can have issues related to the hormone aspects of it, such as issues with the heart, with carcinoma heart disease. So we have very talented cardiologists, such as Drs. Chang and Alhama Balado, but also our cardiothoracic surgeons, when medically we need them. And then we also, I think, what's unique here at the Hutch is that we have a lot of supportive services. So when, obviously we're caring for patients over a long period of time, it's not always just about the cancer and the treatments, but it's also how it impacts their quality of life, the symptoms that they're dealing with. And that's where we have a lot of supportive services here at the Hutch, including with integrative medicine. We're blessed to have Dr. Shannon Fogh from our integrative medicine group participate in Tumor Board 2. But we have palliative care, our nursing teams, and then we have social workers and patient navigations who are critical in terms of, especially finding psychosocial resources, to get through the cancer journey and treatment. And so, if there are people who are interested in coming to see us and getting a formal consultation or management, this is just a highlight of how to get a referral here at the Fred Hutch. This is a link that you can go there, but also if you just go to the Fred Hutch website, there is a link to go to the new patient appointments, and there you can click through this link, but there's also a phone number that's listed there. So if you end up wanting to get a consult, we're happy to see any patient anytime. And to this end, I also want to highlight our support by our patient advocacy groups, specifically from the Pacific Northwest Neuroendocrine Cancer Support Group, specifically the co-chairs, Gary Murfin and Denny, who happen to both be patients here at the Hutch. And so we're very blessed to have their support, and they'll be giving a presentation later about their support groups and such like that. And then also I want to thank Alana Culberson, who's from our Fred Hutch Strategic Clinical Relations. She's done a wonderful job helping to organize this conference this year, and would not have been possible with her assistance as well. And so just want to thank you for her time. And so this is just a review of the agenda for this year's conference. So compared to 2 years ago when we did our first conference, where we spent a lot of time doing lectures and kind of going over about neuroendocrine tumors and such like that, which is great. But sometimes it can be a lot of talks and can be overwhelming. So how we kind of redesigned our conference this year is we'll do some overview of things. So I'll start with a talk about neuroendocrine tumors in general, but that will jump into basically 2 mock tumor boards. So our tumor boards is try to get a sense of basically how we do our discussions of difficult cases and, how that leads to basically treatment decisions. So our first tumor board is focused on the use of liver-directed therapies in neuroendocrine tumors. and then we'll have a short break, and then we'll have a presentation from both Denny and Gary on the Pacific Northwest Neuroendocrine Cancer Support Group. And then we'll have a second tumor board where we'll talk about how we make decisions of using PRRT versus other treatments. We'll end by some clinical trials and some evolving therapies from me, and then we'll kind of end our conference hopefully by noon. And so just some housekeeping issues. This event will be recorded. If you do have questions, please use the chat function, and your questions will only be available to the speakers and the panelists. So obviously sometimes we get a lot of questions, so we'll do our best to kind of consolidate if there's a lot of repeat questions. And then if you end up accidentally leaving the Zoom webinar, you can always click the link and you can come back without any issues. So, and then we do highly suggest that after the event to please come back, complete your event feedback form. This is very critical for us. Obviously, we want to continue to improve this conference and make it helpful for all of you. And so please do share your feedback after a conference about what we could do better for the years to come. And with that, that is the end of the overview. And I'm going to stop sharing for a minute as I switch my presentations. Great. Oh, don't know why that's that one. Okay. All right, and everyone seeing the slides? Okay, all right. Well, I think to kick off the conference, I want to give a very high-level overview about neuroendocrine tumors in general, so that way we can kind of set the precedents in terms of when we discuss the cases. So first, in terms of the outlines for the talk here, I want to give a high-level overview of, we use a lot of terminology in neuroendocrine tumors and neuroendocrine cancers, and it gets very confusing. So I want to set a baseline stage about this so that we can communicate well as we get into our cases. And then we'll talk a little bit of background about the epidemiology, symptoms that it may occur with patients who have neuroendocrine tumors, and then obviously a very high-level over of treatments. So in terms of how we talk about neuroendocrine tumors, so I think first is just what is a neuroendocrine tumor? This is a very common question when I meet patients with a new diagnosis and trying to figure out what this means. So, when I say colon cancer, lung cancer, I think people get that. When we say neuroendocrine cancers or neuroendocrine tumors, it's kind of hard to conceptualize. But essentially, these are cancers that come from hormone-producing cells. So that's why they're called neuroendocrine. So neuroendocrine is part of our hormone-producing cell. And what hormones are, in a very general term, is that these are the chemical messengers of the body. So it's essentially how our organs talk 24 hours a day. So your organs need to communicate with each other so that way they can coordinate all their body functions and you continue to live and do all that you want to do. And so with that said, neuroendocrine cells are actually everywhere in the body. So that should imply that neuroendocrine tumors, neuroendocrine cancers can literally happen anywhere in the body. But in terms of when we take care of patients in clinic, the two most common sites are often the GI tract, meaning our intestines, pancreas, liver, so all our abdominal organs, but also followed by the lung. But that doesn't mean that they're only sites. There's other sites as well too. I'm going to really focus a lot on the GI neuroendocrine neoplasms, and neoplasms is just a general term, and they'll make sense in the coming slides. And then sometimes we might not know the site. But just so you're aware of the terminology, when I say gastroenteropancreatic, that's what we often use in the field, because in our abdominal area, we've got so many organs, liver, pancreas, small intestine, that it gets hard to really say. So sometimes we have to combine everything. So that's what we mean by GEPNEN. So GEPNEN is just saying gastroenteropancreatic, meaning combining all the organs in the abdominal tract altogether. So in terms of what is important information when I meet a newly diagnosed patient, so first is, obviously, we always say in oncology, tissue is the issue, meaning that I need tissue, I need a tissue diagnosis, and I need to know what kind of cancer it is to best how to treat it. In neuroendocrine tumors, it's also not just knowing that it's a neuroendocrine tumor, but there's a couple pieces of information that I need to really kind of get a sense of how aggressive the cancer is, and how aggressive the cancer is dictates in terms of how best to treat my patient. So two pieces of information how I can get that is, one is what we call differentiation. So that's basically saying that all cancer cells come from parent cells, from normal cells, but sometimes those cancer cells might look similar to the normal cells, and that's what we refer to as a well-differentiated neuroendocrine tumor, as opposed to when they've changed their appearance so much that they're much more aggressive process, a poorly differentiated neuroendocrine carcinoma, and we'll come to that. So it's really trying to get the understanding, is this a better behaving process or is this a worse behaving process? But then even if you're a better behaving process, we have to understand that sometimes cells are growing quickly, they're dividing quickly, so they're growing faster. Sometimes they're growing much slower. So also need an idea of the growth rate, and that's what we mean by grade. So how we assess grade is that there's a special stain that we can do on the cells to kind of measure that growth rate. So really at the end of the day, what I'm trying to get a sense is, are we dealing something really slow growing or something that potentially is faster growing? And then obviously we also want to know what is the primary site. So even though all neuroendocrine tumors have similarities, um, depending on which site, where, for example, if it's lung, if it's pancreas or small intestine, some of the treatments respond a little bit differently to each of these cancers. And so we need to know that. And then obviously also depending on the site, if let's say we're trying to remove these tumors surgically, that affects the surgery operation and the complications related to that. And then some of the tumors might have their own complications, which we'll kind of talk about in the coming slides. And then the next part is staging. So staging is trying to figure out, are we dealing with a localized disease where we can talk about potential treatments with the aim, not always a guarantee, but with an aim of getting rid of the cancer? Or are we dealing with spread to different places where now we're really focused on treatments to try to keep the cancer under control for as long as possible? And so how we get that information is from our CT scans, MRIs. We'll talk a little bit about dotatate PET scans, which is a specific type of radioactive scan where we're really looking another way at the neuroendocrine tumors, where we're looking at what we call somatostatin receptor expression. So this is a protein that's on the surface of the cells, and it serves as kind of an on and off switch for tumor growth, but an on and off switch for also hormone production. And we'll talk a little bit about that, how that leads to symptoms. And also these scans helps us determine kind of appropriate treatment options, and this will be further highlighted in the tumor boards. And then we also want to know that not only are we trying to control the tumor growth, but because these are tumors, that makes hormones. And if you make too many hormones, it leads to symptoms. It also is important for us to know if those hormones are leading to those symptoms, because we also want to treat those symptoms to improve the quality of life for our patients. And part of all of this is that there is no one size fits all. So every single patient that walks into my clinic behaves differently, does things differently. And so even though there are general principles that we follow, each patient's situation is very unique, and we try to tailor to that patient's specific situation to give them the best treatment. Now, one of the things in terms of terminology that I want to get to is that we use a lot of terms, and one of the terms that still floats around, which we still use, is called carcinoid. And how this came about was a long time ago, back in the 1800s, where a German pathologist essentially recognized, they knew what cancer was, and the medical term for cancer is what we call carcinoma. But neuroendocrine tumors look a little bit different under a microscope. So at the time, they said, well, it looks like a cancer, but it doesn't really look like a traditional cancer. And that's where carcinoid was the German term of basically cancer-like. And then basically cancer-like became carcinoid, and that just came perpetuated. And while we still use this term, it's kind of one of those terms that really confuses us and doesn't give us a lot of information. And so from that, we've had a lot of iterations in terms of how we define neuroendocrine tumors. And so I want to introduce in terms of the WHO, the World Health Organization classification. So we want to be able to discuss neuroendocrine tumor patients on an international scale. And so from this, as I mentioned, the two pieces of information that I want from pathology is differentiation. So a well-differentiated neuroendocrine tumor is a better behaving process, as opposed to a poorly differentiated neuroendocrine carcinoma. I'm being intentional by my terminology there to try to specify a much more faster growing, much more aggressive process. But then, as I mentioned, even if you have a better behaving neuroendocrine tumor, some are slower growing, some are faster growing. So I need a measurement of how quickly the cells are dividing, and that's where the grading comes in. So in well-differentiated neuroendocrine tumors, we have a grade 1, grade 2, grade 3, and that's just to imply grade 1, much slower growing, grade 3, a little bit faster growing. And this third category is kind of a new category that was developed over the years. And the reason why this all matters is is really to help inform patients in terms of prognosis. So on here, the left is looking in terms of average time, in terms of how long patients may live. And on the top is basically somebody who has a very slow growing tumor, well differentiated grade 1, grade 2. Even in the setting where cancer may have spread, patients can live sometimes many years and decades, right? So it becomes more of a chronic disease. Now, if we're dealing with a neuroendocrine carcinoma, this is kind of the most aggressive form. Survival is often in that group of patients a year or less. But then this well-differentiated grade 3, they're not necessarily these really fast growing. They're not really that slow growing. They're somewhere in the middle. And this group, we still are trying to best define about how best to treat them. We used to treat them like this really kind of aggressive form, but we end up finding that some of the treatments that we use in the most aggressive form don't even work as well. It's that we use the treatments for slow growing neuroendocrine tumors that sometimes can work. And again, a lot of studies are kind of focused on that. Now, in terms of the lung, just to introduce, compared to our GI neuroendocrine tumors, lung has a different category. So they have a category called typical, atypical, small cell lung cancer, large cell lung cancer. We won't get into too much today. But really, I think even though we have different terminology, on the bottom, it's really demonstrating that really our language that we're talking here, so we're just trying to get an understanding of, is something much slower growing or is something faster growing? And again, that influences treatment decisions. Now, in terms of, when we're talking about diagnosing neuroendocrine tumors, this can be challenging because neuroendocrine tumors oftentimes are what we call the zebra. So, we're taught in medicine that to recognize the horse, the most common thing, but neuroendocrine tumors is not always the most common thing. So it's often the zebra that you have to pick out. And what I mean by that is that oftentimes patients with neuroendocrine tumors may not have symptoms, but if they do have symptoms, their symptoms can mimic many other medical conditions. And so sometimes it takes a long time for us to think about whether this might be a neuroendocrine tumor, which sometimes one of the things with neuroendocrine tumor patients is the frustration often of how long it takes. And so I think it's just recognition of basically of these symptoms. And when we've ruled out everything, to think about, is there a possibility of a neuroendocrine tumor? Now, I think in terms of how prevalent neuroendocrine tumors are, we do call this a rare disease, although I will say that's probably changing over time. These lines just represent from large databases about, compared to the top line, which is the incidence of all cancers, which is pretty high. This yellow line is below, but you can see we are starting to exceed even with that. And I think part of that is just the increased awareness and also diagnosis with our scans and such. But turning around from neuroendocrine tumors, I also want to highlight neuroendocrine carcinomas. This is a much more rare type of cancer, so much less common. And so one type of neuroendocrine carcinoma that we see in the lung is called small cell lung cancer. This is highlighted by the pie chart in the top left. That represents the majority. But then there's also what we call extrapulmonary, so neuroendocrine carcinomas that occur outside of the lung. And I'll bring that up because we don't know if the treatments that we do for lung cancer are the same here for extrapulmonary, and we'll highlight this later in some future slides. So in terms of, what are the symptoms some patients may get with neuroendocrine tumors, one, it could be related to tumor, but also could be from hormone production. And so just to introduce the concept of what we call functional tumors. So functional tumors is not only just saying you make a hormone in the blood, but you make a hormone in the blood and it leads to symptoms, okay? So basically, it's not just saying that you've got the hormone being secreted. And one of the most common is often from small intestinal neuroendocrine tumors and also some lungs, what we call carcinoid syndrome, where you make too much serotonin, and that leads to characteristic symptoms like flushing, diarrhea, sometimes issues with the breathing, and also effects on the heart. But then carcinoid syndrome is not the only thing. You can make other hormones. So for example, from the pancreas, there's very unique hormones that leads to very unique symptoms. And it's just to recognize that carcinoid syndrome doesn't explain everything. Now, one of the things is we've got a lot of blood markers that we can actually check, and I just want to highlight, oftentimes we might check all of these, but really when we're checking hormone markers in the blood, we're really checking them to figure out if the symptoms are related to hormone to help dictate treatments. So really, we don't need to check everything all the time. And so really it's more of following based on the clinical symptoms. And I bring this up because chromogranin A is one of these blood tests that we've had for a long time with the hope that we think that it can predict disease and such like that. Although I think we realize that chromogranin A actually has very poor correlation with disease status, so it doesn't always predict if it's getting worse or better. It also doesn't change our management many times, aside from when we look at imaging. And so just want to highlight there's been updated guidelines as we've been reviewing all of the data that now the recent guidelines have recommended against the use of checking chromogranin A for diagnosis and treatment response. And now more incorporating about disease biology, right? How quickly the disease is growing and following it with scans and following the patients to really make appropriate treatment decisions. And then we'll talk, this is carcinoid heart disease, just to recognize this is a thing that can occur when you make too much serotonin, where it can damage the right-sided heart valves, and that leads to leaky valves that can lead to heart failures type of symptoms. And so really it's just important to recognize this because if patients do have heart failure symptoms, it's important to establish care with a cardiologist. And if it's really severe, being evaluated by a cardiothoracic surgeon to have these valves replaced because medical treatments don't fix the valves because the hormones have led to a lot of damage to artery valves that are reversible at that point in time. And then also with small intestines, there's also the risk for bowel blockages and stuff like that, which is why we talk about doing a primary surgery on the primary tumor to try to reduce that risk and also deal with bowel obstruction. And then we talk about, often a common question I get from patients is why did a neuroendocrine tumor develop? Oftentimes we don't have a clear reason why neuroendocrine tumors develop, but that's just to highlight that there are hereditary syndromes, meaning something that you got from mom and dad that made you more prone. And these are some of the hereditary syndromes. MEN1 is the most common, that puts you at most risk, oftentimes associated with an increased risk for pancreatic neuroendocrine tumors, but there's others here. And the importance of this is just to recognize this because if there are genetic mutations that you've inherited, it's important to know this not only for you, but also for the rest of your family members for earlier cancer screening. Now, in terms of neuroendocrine tumors, again, a lot of different treatments. We're going to highlight these, but these are kind of four big buckets for the treatment of neuroendocrine tumors. And these include surgery, catheter-based liver-directed therapy, which Dr. Laidlaw will talk about, where we can inject beads to kind of treat tumors within the liver. We have radioligand therapy, which basically is IV radiation treatments, right, that binds the tumors that have the somatostatin receptor. And then we've got our medical treatments, such as targeted agents and chemotherapy. I won't go a lot into this, but this is just to highlight at a very high level when we talk about localized neuroendocrine tumors, that based on the disease site, each of them have their different classifications, how we resect them, and why this all matters is that when you have slow-growing tumors, sometimes you have to think about not only just treating the tumor, but thinking about if it's already slow-growing to begin with, what are the long-term implications of doing a particular surgery? So, for example, like resecting a pancreas lesion in the head leads to a Whipple's procedure, which is basically a very big procedure. And we have to think about what are the nuances of could we just observe the tumor for a period of time versus submitting a patient to a big surgery that might have long-term implications. So these are really high-level overviews of the medical and treatments that we have for neuroendocrine tumors. I'm going to highlight these some in the tumor boards. But basically, how I kind of divide it up is essentially we kind of divide up as pancreas and not pancreas. And the reason being is because some of our treatments work better on pancreas, whereas others it doesn't. Does it mean that we can't use the treatments that we do in pancreas for other ones? No, absolutely not. But it's just more that based on the data, we know that some work better. And so these include some of the drugs that you'll just highlight here just so that you're aware of them. Again, we'll cross some of these treatments as we get into the tumor board discussions as well. And then just very briefly in terms of neuroendocrine carcinomas treated very differently from neuroendocrine tumors because these are such faster growing kind of cancers. We have to often use aggressive chemotherapy to treat these patients. And our current treatment is really kind of extrapolated from neuroendocrine cancer of the lung called small cell lung cancer. But these are cancers that come from smokers. My patients with extrapulmonary, meaning neuroendocrine carcinomas that occur outside of the lung, these are some of my healthiest patients, and they just get a really bad luck cancer. And so part of that is important because the biology of how they develop in the context of smoking or not will often dictate about whether treatments might work equally the same. And so this is just to highlight that we don't really have a great standard of care, and we'll talk about studies in terms of how we're going to try to improve outcomes for patients with neuroendocrine carcinoma. So just to summarize, in a very high level form, neuroendocrine tumor is very nuanced. Each patient's very different. So, like I said, there is no one size fits all, and that's why it's very important that we actually have to have a discussion with our patient about what the goals of treatments are, what are the side effects, and then really having a multidisciplinary discussion, which we do in our tumor boards, where we try to figure out what it could be the potential best plan for our patients. And so with that, I end there with the overview. And I think we have a few minutes for questions. So I'm going to stop sharing here for a minute. So please go ahead and post your questions in the chat and we'll kind of review those. But a couple of questions that we're hearing here is, can Agent Orange cause NET cancer? I think Agent Orange in general can actually cause a lot of different types of cancers, not just neuroendocrine tumors. In terms of kind of the specific link, I don't know if it's as well studied for neuroendocrine tumors as compared to other cancers. So I think my answer to that is there's always a possibility, but in terms of how strong that association is not as well defined. So, and then I think there was a comment by one of the attendees about, is there any role for radiation therapy for liver tumors? It's not on your list. And yes, radiation is definitely a common thing. I think one thing we don't always talk about is that we prefer a lot of our other treatments like the liver-directed therapies and such just because it's been studied more. And even though I don't discuss specific radiation, because radioligand therapy is basically a specific type of radiation, it's just delivered a little bit differently. But yes, radiation can be done for select situations if, let's say, it's just one or two spots that might be growing. So. All right, looks like we've got a lot of more questions coming through. So it's one question is, what's the likelihood that GI tumors can metastasize to other areas like the pancreas or lung? Yes, they can, these tumors can do whatever. They can metastasize to many different places. Oftentimes, though, I would say within the GI tract, most common sites often stay within kind of the abdominal space. That's not to say I've never seen a lung metastasis, but more often than not, they're going to metastasize more in the abdominal space than they do the lung. But again, that differs also depending on the aggressiveness of the cancer and such like that. So. We also have a question about histotripsy is a helpful method in debulking. Dr. Childers, I'm going to let you kind of weigh in on that one. So,
yeah, thanks. Histotripsy is a fairly novel technology. It's only been in practice for a couple of years now. The data, and just to reframe things for participants. So histotripsy is a ultrason. The best way to think about it is it's an ultrasonic way of ablating tumors. It technically is not a form of ablation. It actually causes this thing called cavitation and kind of destroys tumoral tissue as well as normal tissue. It's the potential benefits of it are that it is non-invasive. It's something that can be done through the skin. You don't have to make any incisions. It does still require, it's still a procedure. It still has to be done under general anesthesia. It still has to be done in an operating room or a procedural room. And we are currently still trying to figure out exactly what the best case use is for it. The data is extremely early. There's really only been kind of one major published trial, which was not a randomized trial. It was just looking at outcomes, and it was specifically looking at patients with liver tumors, predominantly colorectal liver tumors, and not a whole lot of patients with neuroendocrine tumors. So I think it's very safe to say, and I'd be curious any of the other panelists that we really don't have a lot of longitudinal data to know its efficacy in neuroendocrine tumors. And then, I think the other thing is that it has to be, I think the key is that there are probably certainly situations where it's going to be useful, patients who have superficial tumors that are adjacent to really important blood vessels, but we're still trying to figure all those things out. And I think the emphasis, which I'm sure everybody on this call will agree with, is that when you're considering any of these therapies, the key is to do it in kind of a multidisciplinary fashion when you've got experts in all the different fields, kind of figuring out what the best treatment option is. That was a long answer to the histotripsy question, but um, hopefully it was succinct enough.
Yes. Thanks, Dr. Childers. Um, and I'm kind of perusing through the list, so I'll kind of jump up to some questions that I think I might have missed. So I think there was a question regarding appendiceal neuroendocrine tumors and are they higher risk for new tumors? So I'm kind of reading between the lines, so appendiceal neuroendocrine tumors, we didn't, have time to really get into the specifics of that. But that's kind of a very different entity, and oftentimes when they're caught localized, meaning that they haven't spread anywhere, it's often a very, very, very slow-growing indolent tumor. It depends on the size of the tumor when it's diagnosed. So the larger the size, there might be a higher risk of it coming back. Smaller size, oftentimes the risk can be pretty low. So it really depends on kind of the characteristics of what we find at the time of diagnosis. Um, and then questions surrounding of, taking excess hormones, chemical exposures, and stuff like that. So no, testosterone in itself doesn't necessarily lead to neuroendocrine tumors. Just because while that is a hormone, it doesn't necessarily impact this specific type or the relevant hormones that lead to the growth. And in terms of studies about chemical exposures and stuff, again, just kind of like the Agent Orange. There's always that possibility, but in terms of how do we direct that link and everything like that, I don't know if we know that for sure. There's always that possibility, and I think there's a lot of research about looking at environmental exposures. And then I think there's a question about Merkel cell and papillary thyroid cancer. So papillary thyroid cancer is a very different cancer. So the thyroid is a endocrine gland, but the papillary thyroid cancer comes from different cells that are not necessarily the neuroendocrine producing cells. So that's a very different cancer managed differently. Merkel cell is a neuroendocrine type of cancer, and we actually have nationally renowned experts who deal with Merkel cell. And so part of that, we're not focusing a lot on Merkel cell here, even though it's a neuroendocrine cancer, just because the treatments that we have available for Merkel cell actually are very different compared to neuroendocrine tumors that we manage. And so just highlight that we also have separate conferences dedicated to Merkel cell there. And then one of the questions was about, again, the chromogranin A. Sorry if there were any other audio issues as I was presenting, but as mentioned, chromogranin A is a very poor marker of disease status. And so just to summarize, just based on recent guidelines, updated guidelines, expert panels have basically suggested that we need to stop checking chromogranin A and I've seen this often many times in my clinic, where a chromogranin A level goes up or down, but the scans are either stable or haven't changed kind of thing. And it really doesn't change our management. And if anything, it just gives us as providers anxiety as well as the patient's anxiety, right? So I think part of it, that's why the updated recommendation is that they're recommending against checking chromogranin A. So. And we have a lot of questions coming through. Would you take clinical action based on a NET test? So just to give an idea, so NET test is one of these tests that we've had around for a long period of time. And basically, it's a test that you do on the blood to look for the presence or absence of certain genetic abnormalities. And apparently, based on that, you get a risk score in terms of can that predict, the chance of the cancer progressing, getting worse or not, or treatment response. I would say that I think for that is a very hot topic within the field. And while that test has been around for a while, it's never been validated in a very large study about how good it is. And so my big thing is that I have many patients who get the test, and I don't have a problem checking the test, but I also counsel that just like the chromogranin A, sometimes the test correlates well, and sometimes the test doesn't, right? So I think to answer your question, no, not necessarily that I'm going to take a clinical action purely based on a NET test. It's taking all the pieces of information together. How is my patient feeling and imaging and how that all looks like. So. And same thing goes for serotonin, right? All of our blood biomarkers and stuff like that, very poor, which is why in our national guidelines, as I highlighted kind of thing, these are not markers that are really reliable for treatment response. It's really if we're checking these markers, if let's say we're trying to figure out, if the symptoms are related to excess hormone production, which then leads us to think about treatments, how we can try to suppress that to help with symptom control and such like that. All right. And then in terms of, I know there was a random question about dip necks. Again, a lot of different types of neuroendocrine tumors. So I wish we had the time to go over everything kind of thing. But I would say dip necks is just this form of neuroendocrine tumor that occurs in the lung, often very small kind of cells that occur within the airways. And when it occurs within the airways, that leads to patients kind of having shortness of breath and stuff like that. However, it's often a very, very, very slow growing type of process. So it's not necessarily the tumor growth that we worry about. It's more of the tumor causing symptoms and trying to manage the symptoms related to that. And in terms of ablation and stuff like that, it depends on the situation. It really is more, I see this as more diffuse in the airway, so it makes it kind of challenging from that regard. So. In terms of the immunotherapy, we'll come back to that. That's part of the clinical trials discussion, part of that. And then, I think there's a lot of specific questions in terms of unique situations of your own cases and stuff. So I would highlight, part of I can't necessarily give medical advice directly here without, breaking private information. And also, when we make medical treatment recommendations, like I said, each patient's different. So part of that, I will be limited in terms of kind of giving specific advice, but we can kind of talk about high level questions about things. So I know we're getting close to our time for our next session, so I want to be cognizant of that. And so I'm going to go ahead and make the transition over to our first tumor board over on liver-directed therapies. And then I'll be working in the background that if there are questions that come through the chat, feel free to put them in and we'll answer them as best as we can. So with that, I'd like to introduce Dr. Childers from our surgical oncology group, Dr. Laidlaw from our interventional radiology group, and also Dr. Chen, who's going to do the first mock tumor board regarding the use of liver-directed therapies in neuroendocrine tumors.
Great. Thank you so much. And I'm just helping to facilitate the conversation. Really, Dr. Childers and Dr. Laidlaw will be presenting their cases, and we actually are going to be focusing a little more broadly on localized therapies, including liver-directed therapies. So let me just share my screen. Oops. Can everyone see that? Did I share the right screen?
Yes.
Yes. Good. Okay, perfect. Okay, great. So our first case, Dr. Childers, I'll let you take it away.
Sure, thanks for this. So this will be a little bit artificial, but hopefully it'll be kind of informative to show folks kind of how we think through things. We've got some really interesting, complicated cases later on in the program today. And so I thought we might start with something that I see every day in my clinic and kind of start with maybe not a straightforward case, but something that's a little bit more easy to digest. And so, all of these patients are going to come into one of our clinics. We're going to present them in a multidisciplinary fashion to a group of our peers, including radiologists, medical oncologists, interventional radiologists, et cetera. And so this is kind of how this would go is I would start by giving kind of a one or two liner about the patient that I'm interested in discussing. And so, we've kind of concealed identities here. So this is a 45-year-old male that had initially presented with actually back pain, had undergone a CT scan that showed some liver lesions, and ultimately was recommended to undergo an MRI of their liver. And then in turn, that showed a pancreas mass. So this kind of circuitous route is pretty common for us to see folks with. The patient comes to my clinic. I tell them, the patient really has no symptoms at this point. That back pain that initially prompted the CT scan has gone away. They have no significant medical or surgical history. And then quickly, we go straight into a review of the radiology. And if you want to go to the next slide, Dr. Chen. And so then our radiology colleagues would run through the different imaging studies that we have on that patient. And some of our patients have years of scans that we will review as quickly as we can in order to be able to look at how things have evolved over time. And so this individual had a CT scan, and then Dr. Zhen had already talked about this specific type of PET scan that we can get for neuroendocrine tumors called a dotatate PET scan that binds to serotonin receptors and is very specific at identifying neuroendocrine tumors. And so if you look at the images on the left, we've got some beautiful red arrows that are pointing to the area of concern. That is an abnormality in the tail of the pancreas, just to orient folks a little bit. we can see that red arrow that's pointing to the tail of the pancreas. Just behind that and to the left, that's your kidney. That's the left kidney. Just behind that to the right, in the top images there, that is your spleen. And then everything over on the left-hand side of the screen is pretty much all liver, for that individual. And so we see this abnormality in what we call the tail of the pancreas. So that's the part that's closer to the spleen of the pancreas, and that's abnormal. We then have the PET scan, the dotatate PET scan, that you can see is lighting up. It does light up the spleen. That's pretty normal. Dr. Chen can maybe tell us why that's the case. But it's also lighting up the abnormal tissue in the tail of the pancreas. Dr. Chen, I don't know if there's more that you can add
Yeah.
to these images.
Sure, just a few quick comments. So yes, on dotatate PET, the spleen is usually the most avid lesion. I don't know where my pointer here is. And that is because there is some somatostatin receptor expression in lymphocytes, and that is quite avid. And that's one of our reference organs for looking at the intensity of uptake in the tumor. So you can see that you might actually can barely see it maybe above the spleen, and that indicates it has very high dotatate uptake. And some people have heard of the Krenning score. We use it more in the context of deciding whether patients should get a PRRT, and so we'll limit that conversation there. But just that's very typical for low-grade neuroendocrine tumors, especially pancreatic or GI origin, to have this very high uptake. And then similarly with the three-phase CT, so sometimes patients will ask why their neuroendocrine tumor wasn't detected on a standard single-phase CT, and I think this illustrates why. So you can see that this is hard to see. You can still actually see it on this particular CT, and that probably would have been caught 99% of the time. But you can see much of it looks like the rest of the pancreas. So on CT, that's why Dr. Childers mentioned the MRI. Unfortunately, we didn't have the MRI images, but once they see an abnormality, they get the MRI because it better characterizes these. It's much easier to see it. You can get a lot more images with the contrast enhancement. In this case, you can see it's hypoenhancing, and then it hangs on to the contrast later. So whether you get a CT or MRI, that's why usually we recommend multi-phase CT or MRIs to detect these neuroendocrine tumors, because they can be difficult to see otherwise.
Awesome.
Great.
And so at this point, we would probably pause and we would maybe have a little bit of a discussion. As I mentioned, this is a relatively straightforward case. We see that there is likely a neuroendocrine tumor in the tail of the pancreas, and it's isolated to just the tail of the pancreas. We don't see any lesions anywhere else, for example, the liver or the lungs. One could make an argument, I think, that this patient probably didn't need any additional workup before proceeding with some sort of definitive treatment. But oftentimes when patients present to us, they've already been further evaluated, and most typically that will have been through a biopsy. Those biopsies are typically done by our gastroenterologist. So you can potentially get a needle into these tumors just through the skin into the tumor itself, but it's a long ways to travel, and there's important things in the way for a lot of patients. And so sometimes the easiest way and the safest way to get a diagnosis for folks is to have our gastroenterologists put a camera down the throat into the stomach. The stomach sits right on top of the pancreas. They can then use an ultrasound, and just going through the wall of the stomach, they can put a needle into the tumor and get a sample of it. So this patient had already come to us with a biopsy, and that had confirmed the diagnosis of this being, to Dr. Zhen's point, a grade 1 because of the index being 2%, well-differentiated neuroendocrine tumor. And so we would kind of pause at this point. We've kind of reviewed everything we know about the patient. We have their history and their background. We have their imaging. We have their pathology. And we would have a conversation about what we think is the next best step. For this patient, there wouldn't probably be a ton of nuanced conversation. The general recommendation, for somebody with a relatively large, this looked like it was on the size of 5 to 6 centimeters. It's a resectable, in other words, it's a removable tumor. And so the recommendation from our tumor board was to go ahead and surgically remove it. Let's go to the next slide, because I can tell you how this individual did. We will, for the most part, try to do these operations, if possible, through a minimally invasive approach. So that means making small incisions and taking it out using kind of long, skinny instruments. folks frequently ask me, like, what is this whole robotic thing? And I want to be very clear that it's not a robot that's operating on you. There is no independent thinking of the robot in order to do this operation, maybe one day, but for now, what we mean by robot is it's just a form of minimally invasive surgery. So we still have these small incisions, we have these ports that are going into your abdomen, and then we dock a machine that we call the robot to those ports. And then I control at a console right next to you another machine that will allow me to manipulate instruments inside the abdomen. And so it's not doing anything on its own. It can't move without me specifically moving things, but it provides us a lot more precision with the way that we're doing these operations. Historically, we used to do them just laparoscopically with these instruments that you can really just move up, down, left, right, and that was pretty much all you could do with them. Whereas the robot, they have 360 degrees of motion. I basically have little mini hands inside of you through those small incisions, which allows us to do a lot more intricate work. We can advance kind of the patients that we're offering minimally invasive approaches to, because if you've got something that's really close to an important blood vessel, we can do a lot more delicate work using the robotic approach. And so this patient underwent what we call a distal pancreatectomy. So that's removing kind of for this patient, it was about a third of their pancreas, kind of the tail of their pancreas. And we routinely take the spleen out during these operations pretty commonly, not uniformly, but oftentimes we do. Patients often ask me why we do that, and it's really twofold. The number one reason is really a safety reason. So the splenic vein, the vein and the artery that go to and from the spleen run right behind the pancreas. And trying to separate the pancreas off of those blood vessels can be very dangerous. And so if there's any concern that we're going to cause significant bleeding in the operating room, the safest way is actually to divide those blood vessels formally at the same time as dividing the pancreas. So oftentimes the spleen has to come out as a safety issue. And the other thing is that this is a cancer operation. We're doing cancer surgery. And one of the things that we want to know after your cancer operation is not just we want to make sure that we've removed your cancer, but we also want to make sure that we fully understand that cancer. And so we want to know the size of that cancer. We want to make sure that we have a negative margin, that we've basically taken a little bit of normal tissue so that we feel comfortable that we've taken the entire cancer out. And we also want to provide you with prognostic information after the operating room. And one of the things that's very useful is to know whether or not that cancer had spread to any of the lymph nodes. The lymph nodes, for the most part, when we're doing a distal pancreatectomy, live over near the spleen. And so by taking the spleen out, we get a lot more lymph node tissue and we can fully stage your cancer afterwards. This patient did really well. We got the final pathology that showed a 7 centimeter mass. Margins were negative. Lymph nodes did not have any cancer in them. One of the things that we see frequently is that the key 67, the rate of activity, how active the cancer is, will often change in the final pathology specimen as opposed to the initial biopsy. And I think intuitively this makes a lot of sense when you think about how we did that initial biopsy. So the initial biopsy we said was a gastroenterologist putting a camera down your throat, using an ultrasound, looking at the tumor, and then passing a very small needle in and trying to get a little core of that sample. They're only getting one tiny little bite out of the entire 7 centimeter tumor. Whereas when we look at it on the final pathology, we then have 7 additional centimeters of tumor to look at. And when the pathologists slice it up into a million pieces, they will see different kind of activities throughout the entire specimen. And so sometimes you'll find that there are other parts of the tumor that are a little bit more active when you do so. This patient, did really well. Saw him about 15 months later, and currently has no evidence of disease. And we'll keep an eye on this individual for a prolonged period of time. We usually get scans every year for at least 10 years, just to make sure that nothing's coming back and that we don't have anything that we need to go after again. Happy to answer any questions from either our panelists or from the audience about this case. I think the one question that we often get asked, and I just want to spend a minute on it, is how does size factor into the decision making of whether or not you need to have a surgery to have a neuroendocrine tumor removed? And it's a challenging conversation to have with patients. So most of the time when patients show up in my clinic, they have been told they have a mass in their tumor or they have a mass in their pancreas. And of course, they think the worst. They think they've got pancreatic adenocarcinoma. They hear the devastating outcomes of pancreatic cancer, adenocarcinoma, and they are, obviously besides themselves. I then have to kind of go through the process of saying, no, this is a very different type of cancer, behaves very differently. And then we sometimes will even say, we're not even going to recommend doing an operation, which is just is a challenging thing to reconcile, right? You're coming in with this perspective that you've got a cancer diagnosis, that you've only got a year or two to live, and now I'm telling you you've got a relatively benign a behaving cancer. You may not need surgery at all, which is a big frame shift for folks, and we have to spend a lot of time having that conversation and explaining things. Just to kind of, cut the story short, because I know we've got other cases to get to. General recommendations are if it's less than 1 centimeter in size, we typically do not recommend surgically removing those tumors because most likely they're never going to grow in size. Most likely they're never going to spread. Most likely they're never going to become a problem. If they're over 2 centimeters, we generally do recommend removing them. And then there's this controversial size between 1 and 2 centimeters where we're still trying to figure it out. The best data that we have to help kind of guide patients in terms of what to do in that intermediate category, that 1 to 2 centimeter category, comes from the Aspen trial. We're still awaiting final results from the Aspen trial, but essentially they took 1,000 patients with sub 2 centimeter neuroendocrine tumors, pancreatic neuroendocrine tumors. And they asked as many of them as possible to just keep an eye on the tumor as opposed to going to surgery. About 90% of those patients ultimately just ended up going on what we call active surveillance. They're just keeping an eye on it every year with a scan. And almost none of them, I can't say none, it's actually 3 of the 900, almost none of them developed any type of advanced disease, metastatic disease. And so we have about a 99% certainty that those patients are not going to develop metastatic disease, and it's probably safe to watch patients who have tumors in the 1 to 2 centimeter range. But it's a nuanced conversation, right? If you're 30 years old versus 80 years old, it's a different conversation. If the tumor is just a little spot right in the tail of your pancreas that's relatively easy to remove as opposed to it being in the head of the pancreas, these are nuanced conversations and conversations that we have with every patient, and we have to make sure that we're kind of tailoring the conversation appropriately. I think we've fully covered that first case. Maybe we could.
Why don't we go on to the next one?
I think so.
Okay, just there we go. All right, case 2.
All right. This is an interesting kind of challenge that we deal with pretty frequently, and I would love other panelists' thoughts on how to manage these ones because it's still a challenge. So again, these patients often will have kind of a little bit of a circuitous route to getting to us. So this was a gentleman that presented with a kidney stone and had a CT scan for workup of the kidney stone. Well, the CT scan showed the kidney stone, but it also showed some abnormal lymph nodes next to the pancreas. Okay. That patient was referred to medical oncology. Medical oncology said, we need to figure out what this is. Let's try to get a biopsy. And they referred it to their local interventional radiologist. Their interventional radiologist, as I mentioned earlier, said, that's a really tricky spot. I don't think we're going to be able to do it safely. Medical oncologist said, okay, I need to try to figure this out. How else could I maybe get the diagnosis? Let me get a PET scan and see if I can figure out if this is cancer, if it's coming from somewhere. And they were thinking maybe this is some sort of colon cancer that spread to the lymph nodes, or traditional pancreas cancer that spread to those lymph nodes, or even a lymphoma was pretty high on their differential. Ultimately, after the PET scan was done, the patient was referred to surgery to our team saying, can you do a surgical biopsy? And we said, don't worry about that. We can get the diagnosis a whole lot easier. We're going to refer you over to our gastroenterologist who are going to do that endoscopic procedure and do some biopsies of it. And so that's what happened. And they took a biopsy, and lo and behold, it was not metastatic pancreas cancer. It was not metastatic colon cancer. It wasn't lymphoma. It was a well-differentiated neuroendocrine tumor. And so maybe we can go to the next slide and show some of the imaging that we were able to review. And so we had some of these prior images. And specifically, I think the thing that is most interesting is we had the PET scan and we had a CT scan. Again, we've kind of already oriented you a little bit to the things that we're generally looking at. But you'll notice these kind of bright yellow spots on the PET scan in those middle two panels. Those are lighting up those lymph nodes that are around the pancreas. Some of them are around kind of the head of the pancreas, some around kind of the body of the pancreas. Um, and but we didn't clearly see anything in the pancreas. We didn't clearly see anything in the small intestine. We just saw these lymph nodes around the pancreas. And so, Dr. Chen, I don't know if you have anything else you would add to
Yeah.
the imaging.
And so what's interesting is that when you hear the story that Dr. Childers laid out, you can see why. So it is not typical for neuroendocrine tumors to have this level of FDG uptake. And so we have these, this was actually acquired on one of our more advanced scanners that now has deep learning reconstructions, all these fancy words to say that the SUVs are going to be higher than what we see on prior scans. But even so, reference organs are still our best friend in terms of determining whether something, the level of uptake that a tumor has. So you can see that the blackness of these, the brightness of these is actually very similar to the brain, which means the brain is the organ on an FDG PET that has the highest physiologic uptake because the brain is glucose dependent 100%. And so it takes up a lot of the FDG. And so that's really high uptake. So I can understand why they thought it was metastatic disease or lymphoma first, because this would be a fairly typical appearance for a lymphoma, for example. Similarly, the colon cancer is another consideration, but we didn't see anything on the imaging to suggest that, or even a GI source. When you get the biopsy, I think one question arises is whether it, you would consider a dotatate PET at that time. And so I don't know if that was considered at that time, but I would say just based on the FDG, it seems reasonable also to go in and try to get a more definitive answer, because just like Dr. Childers said, when you do those ultrasounds, you're only getting a small piece. Like what if what if that neuroendocrine tumor is only a small portion of something that was more aggressive? So I don't know if you want to comment on because there is variability in whether you get the dotatate PET before surgery or not.
Yeah, good question. We didn't for this case just because of how well they lit up on the FDG
Yeah.
PET. I think our kind of group conversation was we need to fully explore a source of a primary.
Mhm.
And so we got actually, I think, one or maybe even a couple of additional endoscopy procedures. I think it's on the next slide.
Yeah.
To kind of fully evaluate the pancreas with endoscopic ultrasound, to make sure there wasn't an unusual source of a primary, for example, stomach or rectum. And so that was kind of where we focused our effort. And then we said we were going to look in the operating room, right? So we can do intraoperative ultrasound, and we can take a really good look at the entire first portion of the intestines. We can take a really good look at the pancreas and see if we have an occult primary. I think the challenge when you're counseling patients about these operations is, most likely we're taking out quote unquote metastatic disease, but we don't know where it came from. And it's possible that we will never know where they came from. And I'd be curious if any of the panelists, if we have a better understanding of why this happens. But we do see this from time to time where we have patients that we remove the metastatic disease and we don't ever evaluate a primary. Maybe it's our immune system that can effectively fight those primary tumors off, and all we're seeing is the residual leftover disease. If anybody has any insights, please chime in. But we offer basically to get rid of all of those sites of disease, assuming that it is everything that you currently have. And then the plan is typically to kind of just keep a really close eye on things. And if a primary ends up declaring itself, it ends up showing up, we can remove it at a later date. And so that's what we did for this patient. If you want to go to the next slide. Um, you know, we take our time with these operations as we do with all operations, but we really are spending a lot of time focusing not just on the tumors that we know about, but trying to identify an occult primary tumor. And so we look at the entire small intestine and run the entire small intestine to see whether or not there is any evidence of a tiny little tumor sitting in, the ileum. We will do an intraoperative ultrasound of the duodenum and the pancreas. We can do endoscopy during the operation if there's anything that we're concerned about. The nice thing, again, is that most of the time we can get away with doing a minimally invasive operation. We can do all of this robotically now because of the technology that's advanced. And so we were able to go in and we were able to remove what ended up being 5 abnormal lymph nodes. The recovery is pretty straightforward. We're not removing any of the pancreas. We're not removing any of the small intestine. So patients really have minimal pain. They're immediately started on a regular diet the first day after surgery. And so this patient went home on post-op day 2. And I've definitely had patients who have gone home even on post-op day 1 after these operations. Recovery is pretty minimal, and patients are back to normal activity within a couple of weeks. We got the final pathology report. It confirmed that this was metastatic neuroendocrine tumor, and currently we're just getting imaging to keep an eye on things. And right now, just got a scan actually last week that shows there's nothing in the chest, abdomen, or pelvis. He's doing great, had no complaints whatsoever, and we'll just keep an eye on things. And if, make sure he keeps up to date on his colonoscopies and see if anything pops up. But for now, no evidence of disease, and hopefully it'll stay that way indefinitely.
Yeah. Thanks. I know this is a super interesting case. So, and clearly, like a lot of evaluations to try that primary. I was wondering, do other panelists want to comment on
Yeah,
the question about that?
Dr. Chen, I want to highlight a couple questions that's coming through the chat and everything like
Oh,
that.
thanks.
So,
Okay.
so first I'll start off by I want to take one step back about the FDG PET scan, which I know Dr. Chen you kind of discussed about, but just for the audience, obviously dotatate PET scans, right, are looking for the somatostatin receptor, the serotonin, right, producing kind of receptor on cells. And most of the time in slower growing, right, well-differentiated neuroendocrine tumors, they light up on a scan, on that type of scan, as opposed to an FDG PET scan, right, which Dr. Chen talked about, right, which is a sugar scan, right? So the radioactive label is really looking at metabolic activity, so cells that are taking up sugar and such like that. But oftentimes in a slow-growing neuroendocrine tumor, FDG PET scans are negative in a well-differentiated neuroendocrine tumor. So I think Denny asked a question about, at initial workup, most of us have dotatate PET scans, but few of us get FDG PET. So why do we not get both? So kind of beat to
Well,
Delphine or Amir if you would like to chime in on that. So yeah.
yeah, generally we would start with a dotatate PET. As I said, this was outside imaging, so they came in with the FDG PET, and that's why I was actually wanted to ask Dr. Childers about that thought process. They clearly did a thorough evaluation of trying to find the primary, and usually when you get the dotatate PET prior to surgery, that's the purpose of that is because there's not a good sense of where the primary is, and so they're using the dotatate PET. So maybe if you can comment when you decide to do because sometimes we'll get the dotatate PET after the surgical resection. So they have enough anatomic imaging, just like in this case, they had enough information to go and to know what their surgery plan was going to be. And sometimes they will get the dotatate PET though, then afterwards, either if there's something concerning, if they find something on the biopsy that wasn't expected, and then they get the dotatate PET later, or just to make sure as a baseline, so there are various reasons why that might happen. But do you want to comment on that?
Yeah, so I would say probably the most typical patient to show up in my clinic and what we see on kind of the surgery side is somebody that has had a CT scan for some other reason. They see a mass in the pancreas, and they've often gotten a biopsy, or maybe they haven't before they show up, and they usually have not gotten the dotatate by the time they show up in our clinic. I would say even though there's guidelines are a little bit mixed, I think for most of us now, our standard is to dotatate every single one of those patients, mostly in that situation to help confirm the diagnosis, because a lot of these patients you can skip a biopsy in my opinion, and just go straight to the operating room to remove it if you've got a dotatate that's showing a lesion and it's kind of got classic CT characteristics as well. Oftentimes, especially for the smaller tumors, it's actually really hard to make a diagnosis via biopsy for the same reasons that we discussed. You've got a camera in the stomach, the patient's breathing and moving, and you're trying to get a 25 gauge needle into a 1 centimeter tumor in the middle of a pancreas. That's really hard to do with any reliability, and there are some potential downsides to doing so. And so the dotatate can be a nice non-invasive way to get pretty close to guaranteed diagnosis. But the other reason why I think most of us routinely get them is that occult metastatic disease is also pretty common. And so it's not uncommon that you will end up finding that a patient who has, a 5 centimeter primary, you have cross-sectional imaging that really doesn't show anything in the liver, and then you get a dotatate and it does now show that you've got 1 or 2 spots in the liver, which is not a preclusion to surgery. It's just we want to know about that before we take the patient to the operating room so that we can deal with the full extent of what we're dealing with. Every now and then we have a patient that shows up with an FDG PET, and if there's any uncertainty about the diagnosis or if there's any uncertainty about the extent of disease, then we'll repeat and get a dotatate. Now, I think we've talked about the fact that in general, the FDG PETs are typically more helpful for patients with higher grade neuroendocrine tumors, right? So grade 3 neuroendocrine tumors, carcinomas are much more likely to be FDG PET avid as opposed to the lower grade tumors where, they're going to be more likely to be DOTA avid.
Yeah.
Yeah.
Oh, sorry. I was going to ask, do you recall what the Ki-67 was on this one?
It was either grade 1 or grade 2. I don't like that.
Okay. Yeah. Because sometimes, so that's there's a question in the chat on does the FDG PET meaning the high FDG means that this is a more aggressive neuroendocrine tumor, and that is hard to predict. We tend to see more FDG uptake in the higher grade 2, like higher Ki-67 grade 2s, and then in the grade 3s also. So and across all solid tumors, higher FDG uptake tends to correlate with more aggressivity. But in this case, some patients can still do well, even if the Ki-67 is higher. The other question is just really quick: dotatate versus FDG. We will consider that because of that biology. We'll tend to consider both the FDG and dotatate when it is a higher grade 2 or grade 3.
And I think along that lines, I think there was a recent question asking about, do lower grade tumors often develop into higher grade tumors? Not always, but I will say that there's been a lot of interest in the field recently in terms of understanding neuroendocrine tumors now that we're treating more patients over a long period of time. And I think there's a phenomenon that happens in some patients, what we call grade creeping, or sometimes with grade transformation. And that's basically just a term of, as we subject a lot of treatments onto a neuroendocrine tumor, we put selective pressure on those cells and everything likes to evolve. So yes, there are some situations, and we do see this in clinic, where sometimes that starts as a lower grade. Because of all those pressures and everything, the tumor will transform into something a little bit more aggressive, and then that might dictate how we might treat it a little bit differently. So,
Grace, did you have a comment?
I think not specifically for this case. Y'all have covered it great.
Okay, great. Amir, any other comments to add or different perspective on what I've said?
No, I think no, it's well covered. Not great.
Yeah. Okay. Okay, great. Thank you. Let's see if any other questions. Should we go on to the next case then? Are you ready to do that? Okay, great. Thank you so much, Dr. Childers, for those. Dr. Laidlaw, you're up next.
Absolutely. And Dr. Shen, I'm going to have you advance a lot of slides because I have
No
a lot
worries.
of the animation. So apologies.
Just cue me. Yeah, just
all right.
cue me when
Go ahead. Perfect. Go ahead and hit next. So this is a 65-year-old gentleman. His story actually starts quite some time ago. He presented in 2008 with GI bleeding, so having bloody bowel movements. I don't have many of the records from his original presentation because this is in the dinosaur days before electronic medical records. But in workup of his GI bleeding, he was found to have a small intestinal mass with an associated mass in the connective tissue close to the small bowel that contains blood vessels and lymphatics. So he underwent surgery for that. The pathology was notable for a neuroendocrine tumor. I don't have the pathology records, so I don't know what the original grade was or original differentiation was, but presumably it was a well-differentiated grade 1 or grade 2 because he got no additional treatment and was just managed conservatively. And he did great up until 2023, at which point he presented with facial flushing, some palpitations, so suggestive of a hormonally active tumor with hormonal symptoms, a small bowel obstruction, so he was feeling terrible, and then quite a bit of abdominal distension. And if you advance, Dr. Chen, you'll see some of the images from his original CAT scan. This is not a CAT scan that is dedicated to look for neuroendocrine tumor. The contrast timing or the timing of the dye is just designed to show us general intra-abdominal abnormalities. But if you advance to the next slide, what you'll see that I've highlighted with arrows is on the screen left image and the middle image, there are dark spots in the liver that are not normal. So these are concerning for liver metastases. And on the screen right image, if you're not used to looking at CAT scans, this is tough to see, but there is an arrow pointing to a lump or a mass in the mesentery, which again is sort of the connective tissue that delivers and drains blood and lymphatic fluid from the intestines. Additionally, on screen right, you can see sort of big round loops of small intestine showing that he has a small bowel obstruction. So next slide, please. And if you hit advance one more time, based off of the CAT scan, he was recommended to undergo a liver biopsy, which was done by an interventional radiologist at an outside hospital, and that showed well-differentiated grade 2 neuroendocrine tumor. This is all in December of 2023, and shortly thereafter, he got a dotatate PET, which we've talked about extensively, and that showed somatostatin receptor expressing disease in the liver. You can see this, the spleen there is very bright, which we've talked about, but multiple spots in the liver that Dr. Chen is pointing out. And additionally, he's got a few other small somatostatin receptor expressing metastases, exactly, mesentery, a few nodes, a few tiny spots in the bone, but really liver dominant disease. In February of 2024, he was started on lanreotide, long-acting octreotide, and that completely resolved his hormonal symptoms. So this was the point actually at which we discussed him in tumor board. So I think we'll do a little bit of a mock tumor board discussion here. I think when I look at these sorts of patients, I always think about, okay, this patient has liver dominant disease. Is this something that potentially my surgeon could help me resect? So Dr. Childers, I know I don't have the original CAT scan up here. Maybe Dr. Chen can go back to that. But what would you say if I asked you to potentially debulk or resect this patient's liver tumors?
Yeah, so kind of our approach to it is I try to keep things as simple as possible. Whenever I think about resectability of a liver tumor, it's can I take the entire tumor out and leave you enough liver left over to survive? That's kind of the most basic principle of how we think about liver surgery. As folks on the call probably have heard or are familiar with the idea, the liver can quote unquote regenerate. What does that actually mean for folks? What it means is that if I take out the right side of your right side of your liver is gone indefinitely. But what can happen and what does happen is that the leftover part of your liver, the left side of your liver, can grow substantially in order to be able to continue to do all the things that the liver is important to do, creating clotting factors, metabolizing toxins, metabolizing drugs. And so our internal literature, our surgical literature says that I can take up to 70 or 80% of somebody's liver out and they can survive because of the fact that the remnant liver can hypertrophy, can grow over time and accommodate those functions. We tend to err on the more of the taking the 70% out than the 80% side out, but nevertheless, we can actually go through and we can actually calculate how much of the liver we're planning on taking out and whether or not that's going to be enough to leave somebody with enough liver to survive. And we can even do kind of these crazy two-stage operations where we go in and we actually cut off the blood supply to one side of your liver in order to grow the other side of your liver a little bit before we do the operation. So we try to be as aggressive and as we can. For this specific case, there's the challenge that you can see in that left panel is that you need a left hepatectomy in order to clear that bulky tumor on the left side of the liver. And unfortunately, what is being shown very nicely on that image is that tumor is straddling what we call the bifurcation of the right anterior and portal pedicles and posterior pedicles, which means you have to do a right hepatectomy. A left hepatectomy and a right hepatectomy takes your entire liver out. So it's not physically possible in this patient, at least right now, for us to do a surgery to fully remove those tumors. If they shrunk substantially, could you potentially get to a point where you could do something? Possibly, but at least based on this current imaging, it would not be feasible.
Perfect. Thank you. And then Dr. Chen has sort of advanced to the image showing the results of this patient's dotatate PET scan. I think the other things that we would talk about in liver tumor board are All right, does it make sense just to continue with conservative management at the moment? The patient's symptoms have resolved on octreotide. Maybe octreotide is going to be sufficient for this patient to control disease for the moment. We could talk about the procedures that I would do. And then I think the other option that we would talk about is the sort of treatment that Dr. Chen and Dr. Iravani provide, which would be PRRT. So Dr. Chen, would you comment maybe at this point in the patient's progression, what would you say to this patient about PRRT?
Um, it's the uptake. So when I was talking before about that Krenning score, we're looking at whether there's uptake above the liver or above the spleen. So in terms of intensity, just looking at purely, are we going to get enough lutein dotatate? We are going to target it with the PRRT. It's not the highest. So, I mean, so it's clearly above liver. So that's our minimum level of first pass of, yes, they're probably eligible. Especially if they're asymptomatic, and the fact that these aren't higher than the spleen, so like they're not the highest dotate avid lesions. I don't know if PRT would be the right next step per se in this, especially because they're doing really well on somatostatin analogs. And I apologize, I already forgot what the Ki-67 was in terms of the biopsy, but if it's overall stable, they're doing well, and they're pretty well controlled on the somatostatin analogs, I would not necessarily jump to PRRT right now.
Beautiful.
Yeah.
Well, we are internally consistent because what we recommended as a tumor board was conservative management. So if you would advance a couple of steps for me, we'll move on to the next slide. We just said, let's watch and wait and see how the patient does on lanreotide. He continued to develop some additional abdominal distension through about the summer of 2024, but otherwise remained asymptomatic. So no hormonal symptoms, no recurrence of small bowel obstruction, but we got repeat imaging in June of 2024. So what I'm showing here on the top left are comparison images between his initial diagnosis and then June of 2024, looking at that biggest liver metastasis on the CAT scan. I've measured it for you. You can see that it has grown. And that was overall reflective of the patient's hepatic disease or liver disease. So multiple liver metastases had grown. And then if you look at repeat dotatate PET images from 2024, you can see that there has been progression of disease in the liver. So increasing number of liver metastases, which Dr. Chen is circling right now with her pointer, some increasing uptake in those liver metastases, and the extrahepatic disease, meaning the disease that's in the nodes and the disease that's in the bones, that's very small volume, really hasn't changed substantially. So Dr. Chen, if you would advance a couple points, I've just highlighted that.
Oh, I'm sorry about that.
Oh, that's okay, no problem. So overall progression of liver disease with unchanged extrahepatic disease. And so in this sort of circumstance, we've already established, okay, not resectable per Dr. Childers. The patient has had improvement in his symptoms on somatostatin analogs, on lanreotide, but despite that, the liver disease is progressing while the disease outside the liver is staying about the same. And so in that situation, that's one of the indications for what we call catheter-based liver-directed therapy, where I administer some sort of treatment into the arteries of the liver to try to target the tumors. What I'm doing doesn't target at all the disease that is outside of the liver. It is only targeting the disease inside the liver. And so that's why it's a nice tool to use in this sort of situation where the disease is liver dominant and really just progressing in the liver. So Dr. Chen, if you could advance, please. So those of you who have seen me or my IR colleagues in clinic know that we usually spend about 45 minutes explaining liver-directed therapy through a catheter to you. So it's tough just to give you a 5-minute talk on it here. But what we chose to do is a combination of liver-directed therapies for this patient. So for the tumors that are small and scattered throughout the liver, we chose to inject small particles that are designed to flow into the small arteries and capillaries that provide blood supply to those tumors and block up the blood supply to those tumors. The tumors need arterial blood supply to grow and to survive. And so by blocking up that blood supply, we are cutting off their arterial flow and hopefully basically allowing them to shrink or to die. This is not a perfect treatment. Usually a couple of tumor cells will survive that cutoff of arterial blood flow, and so things will eventually come back. But it's nice for small tumors that are surrounded by normal liver because I can get the beads into normal liver as well without damaging too much normal liver. So that's what we did for him in July of 2024 for sort of his scattered metastases on the right side of his liver. You can see on screen left and second from left, I have a small plastic tube that I've guided into the arteries supplying the liver using live X-ray video guidance. And all of those sort of gray dots or spots that you can see, those are tumors, and the lines are the arteries that are supplying them. So I inject those beads. The beads flow forward with basically your arterial blood pressure, and they get stuck in the tumors. And this is a picture that I've taken injecting dye after I have injected those beads. And you can see that those tumors no longer have arterial blood flow into them. That is all blocked up. And so they will start to shrink and die down. On a second from the right and rightmost image, you can see another tumor. This was sort of that larger central tumor that Dr. Childers was saying straddled the portal pedicle on the right. And so I'm injecting beads there, and you can see I have decreased blood flow into that tumor substantially. So Dr. Chen, if you can hit next. I then brought him back about a month later, allowing some time for his right liver to recover. And administered a different sort of treatment to that very large, bulky tumor on the patient's left liver. So this tumor was so large that there was effectively no normal liver left on that left side, or in the at least being supplied by the blood vessel that supplies that tumor. And so if that's the case, if I can spare normal liver, I can actually inject a stronger treatment into the tumor. And that treatment is called Y90. It is tiny glass beads that have a radioactive isotope called yttrium-90 in them. Wherever those glass beads land, they can effectively emit radiation up to a couple of millimeters away from wherever they land. So in this case, I'm showing images on screen left of the left hepatic artery. So the tumors or the artery supplying the left side of the liver. And then in the middle of the screen, you can see I've got a tiny catheter in the artery that predominantly supplies that big left liver tumor. And so I injected radioactivity into that, the yttrium-90. Those beads land in the tumor and they slowly emit radiation over the course of a couple of weeks. And that's what Dr. Chen is showing there, a scan afterwards showing me where that radiation has gone. So next slide, please. And one more next. So this is how he did. He tolerated both of those procedures really well, a little bit of pain and nausea after the bland embolization or the small beads without radiation, and that's very common. But here is imaging a year afterwards. So the largest tumor, which is the one that I treated with radiation, has shrunk down really nicely. It is still alive. There is still a little bit of live tumor there, but the radiation has knocked it back substantially, and that really decreased sort of that abdominal distension that he was having. You can see that central tumor that's being denoted by the arrows. That tumor really hasn't changed in size, and that's very often what we see with bland embolization or injection just of those beads to block up blood supply. The response to bland embolization often will be that the tumors will just stop growing or shrink a little bit, but they will still be evident. And the response can often be a little bit less impressive or less durable than Y90. So that's really why I tried to use it in this case in both different parts of the liver. So if you advance again, Dr. Chen, you'll see I'm showing here the right side of the liver, so the side that I did the bland embolization on. So in June 2024, I'm showing those original tumors, which Dr. Chen is showing you right there. And in June 2025, you can see things again have improved quite a bit. So those tumors have shrunk and or disappeared. And that sort of reflects what we would often see for bland embolization, not a complete disappearance of disease, but at least some stabilization. So next slide, please. Perfect. So this is how he's doing. And sorry, back one more. He remains on octreotide. He's entirely asymptomatic from a hormonal standpoint. And I know that Dr. Zhen emphasized that we don't necessarily use chromogranin to truly monitor somebody's disease status, but it always provides me just a little extra reassurance when I see that the chromogranin has gone down substantially. And certainly that reflects, I think, his imaging in this case, even though it doesn't reflect that for everybody. So I'll open it up to the panel and take a look at any questions in the chat, but anything else that anyone would like to comment on?
Any comments? I was going to comment on something that we'll see sometimes with dotatate PET. It doesn't have to do with the course history and treatment course, but just something for people to be aware of. When we start somatostatin analogs, they often suppress the background somatostatin uptake, dotatate uptake. So you'll see, because I was noticing immediately, like, would you think of PRRT again in this setting now that he's come back with progressing disease? And because the disease, you can see from the dotatate PET, it confirms what Dr. Laidlaw was saying. It was progression in the liver, not outside the liver. It does look like it's more intense. And part of that is because they're on a somatostatin analog that's now suppressing a lot of the background dotatate uptake. So interestingly, there have been a number, like at least 3 or 4 reports I know of that have described this phenomenon and looked at small series, and they've suggested whether actually the somatostatin analogs actually help increase the tumor targeting of lutetium dotatate. So I just wanted to point this out. This does not mean that, given all the discussion, we still probably would not have gone forward with PRT as Dr. Laidlaw pointed out. We'd want to target the liver disease first, and to spare the systemic toxicities from PRT for later when you have a larger disease burden that you're trying to control.
That's perfect. Thank you. Yeah, and I think just for the panel, we almost always sort of have this discussion in our tumor board of, okay, is it liver-directed therapy? Is it PRRT? What's going to be the best thing for this patient? And I don't think there's necessarily a right answer here, but like Dr. Chen said, just trying to target the areas of disease that are progressing in sort of a sniper fashion as opposed to a more systemic treatment with PRRT was what we decided to go for here.
Dr. Laidlaw, I have one question for you with the goal of giving some information just for the audience, and then 2 follow-up questions that were in the chat from much earlier. But first question I have is, I know you talked about embolizations here, and as you know, there's different types of embolization, bland, Y90, chemo. Can you give a high-level overview in terms of the difference or how you might choose one over the other?
Absolutely. Yeah. So when we think about embolization, which is a blanket term that involves injecting particles into the bloodstream or injecting something that's going to block up blood flow in the bloodstream, we have 3 treatments for neuroendocrine tumor, like Dr. Zhen just mentioned. 2 of them involve injecting larger particles that physically block up arterioles, so small arteries, and capillaries. And that is what we call bland embolization, which is just permanent particles, like what Dr. Chen is showing here. Or we can add chemotherapy to that, and that is called chemoembolization. And both of those are absolutely reasonable treatments for really any tumors in the liver, but we particularly like to use them when we know that we're going to be necessarily also embolizing some normal liver, because the normal liver can withstand some cutting off of its blood flow. It has a backup blood supply, and that's a little bit too detailed of a discussion for today, I think. But I use predominantly bland embolization in my practice, and that is based off of the results of a recent trial. It hasn't been published yet, but the abstract was presented at a big IR conference last year, showing really no difference in clinical outcomes between bland embolization or chemoembolization. Again, I'll await the publication and sort of make my final determination as to whether I do bland or chemoembolization. But for now, it doesn't make a lot of sense based on the available data to add chemo because it doesn't seem to meaningfully improve patient outcomes, and it can make people feel a little bit crummier. The other treatment, and the one that I did for this patient here, Y90, is a little bit different. So the glass beads that we inject are actually so tiny that they don't physically block up blood flow. So yes, the glass beads will flow into the tumor and then get stuck there, but they won't actually cut off blood supply. What's treating the tumor is the radioactivity that gets stuck in the tumor that then radiates it from the inside out. And again, I do this particularly in a situation where I'm not going to radiate much normal liver, because the normal liver is actually reasonably sensitive to radiation. I know that a lot of these patients down the road may wind up getting PRRT, which is another way of delivering radiation. And that's not going to deliver much radiation to normal liver, and Dr. Chen maybe can talk about that. But I want to try to spare normal liver any exposure to radiation that I possibly can. So I really only try to use Y90 if I'm just going to be delivering radiation entirely or mostly within a tumor. So again, that decision making can involve a long conversation with patients, but that's the high level overview.
Thanks, Dr. Laidlaw. And one immediate question following that just came in was, with bland embolization, do the tumors eventually come back and grow more later?
Yes, that's a great question. The answer is almost certainly yes. The data tell us that the duration of response and really extent of response depends on disease grade, disease differentiation, and whether or not a tumor is hormonally active. So, hormonally active tumors, interestingly, will tend to have a better response to bland embolization than non-hormonally active tumors. And lower grade, well differentiated tumors will have a longer and better response than grade 2 or grade 3 disease. The median duration of response for treated lesions with bland embolization, depending on which paper you look at, is somewhere between 8 and 22 months. So that's a very wide range, but what I tend to tell my patients in clinic is my goal with bland embolization is to kick your disease back months to at most years. I don't know how each patient is going to behave. We know that the disease will come back at some point, but we try to have other tools in our armamentarium down the road, like Y90 or PRRT or systemic therapies to help target it when it inevitably does come back.
Great. Dr.
And
Childers, there was a question from a
yeah,
while ago and sorry, did you want to add something? Dr. Laidlaw, I didn't mean to cut you off.
no, not at all. Go ahead.
Okay. Dr. Childers, there was a question much earlier about, does liver debulking potentially cause avidity elsewhere within the liver as a response to the resection?
Dotatate avidity? I can't say I've seen that, but I don't know. Radiol, Dr. Chen, have you seen any dotatate avidity that kind
Just
of,
for surgical resection?
yeah.
Um, I mean, the only impact it might have, it probably won't change the biology of whatever disease is left is there, but it can change the relative availability of the dotatate for uptake. So if you have a smaller volume, it'll have more availability. But I can't say with any different, like we don't have any data to say that if you debulk the tumor and you have smaller volume disease left, you're now going to see increased uptake in those. So I would say that's not a guiding principle. And usually to see meaningful changes in the uptake of tumor sites, you usually have to have those large, very large changes in the distribution of the tumor. So, but I would say just surgical resection alone, I would not anticipate to change the uptake avidity.
And
Dr.
then
Laidlaw, there was a question for your case of that the blood work in terms of AST, ALT, did that demonstrate liver involvement, like based on lab tests? So,
oh, interesting. So it is uncommon for folks who otherwise have underlying healthy liver tissue to have liver enzyme derangements with this patient's extent of disease. So in this case, the liver function tests were normal. I do make a determination about whether or not I offer liver-directed therapy based on the patient's liver function. So if there's evidence that they have compromised liver function in any way, I tend to be a lot more cautious. But for this patient, they had underlying healthy liver disease and no liver function derangements.
and then I think Dr. Chiorean
Yeah, I
actually
saw.
posted a question. So, can liver embolization or Y90 be used as a precursor to surgery, and are surgery outcomes influenced by the preceding bland embolization or radioembolization? So,
I will let Dr. Childers answer that. Dr. Childers, how much do you love operating on post Y90 livers?
It's challenging. It's very challenging. It's not precluding, and actually, that for other diseases, there are situations that will do actually basically Y90 PVE in order to grow livers prior to doing kind of radical operations. But it really very similar to every other disease site. If you do radiation, external beam, Y90, it creates this dense inflammatory rind that is very difficult to work through, and it makes our operations a whole lot more challenging.
Yeah. I can't say, and I don't know, Dr. Childers, if you've seen this, I can't recall uh doing a bland embolization and sending a patient to surgery. Can you recall that either for neuroendocrine tumor or maybe HCC for someone who's bled and then gone to surgery?
I've done it in the setting of an adenoma before,
Oh, sure.
which is a benign lesion. And frankly, it didn't. I don't remember it being notable. We also do it all the time in patients who have gotten embolized via, as part of a two-stage ALPS or a PVE followed by a second stage operation. And so I think those bland embolizations really don't have any of those side effects that we deal with. The only thing we have to make sure of course, is that if there's coils sitting in an important vessel, that we don't use a stapling device to go across those, because then you don't actually get an adequate seal on those blood vessels, and that can be a problem. But yeah, I think it was interesting you were mentioning that, because when I was looking at the what was left over on the bland embolization, I was like, we might be able to go in and do an ablation on that at this point.
Great.
Beautiful. Well, so Dr. Zhen and Dr. Chen, I have one more case, but it is a complex one, I think, as you
Oh,
all
sorry about
know.
that.
Go, go.
No,
Well,
it
because we have the 30-minute Q&A. So Dave, that's
Yeah,
why
yeah,
I
we're in the middle
didn't
of
take
Q&A.
liberties. Yeah,
Yeah.
because we still have time. So
okay, perfect.
exactly.
Yeah, that works for me. I just wanted to make sure I didn't take
Yeah.
too much time because this is a complicated case. So I anticipate there will be quite a bit of discussion for this one. This is a 35-year-old woman who previously healthy but presented with back pain a couple of summers ago, and on workup with imaging was found to have diffuse disease. So a pancreatic mass that was presumed to be her primary site of disease, with liver, lymph node, ovarian or pelvic, and bony metastatic disease. She underwent a liver biopsy that showed some debate on the pathology, but favored to represent a well-differentiated high grade, so grade 3 neuroendocrine tumor, versus the pathologist thought less likely neuroendocrine carcinoma. She had a very elevated chromogranin, but no hormonal symptoms at the time. So if you advance, please. These are images from her initial CT that was obtained for workup. Again, not a CT that's dedicated to look at neuroendocrine tumor, but just abnormalities in general. And if you advance, you will see arrows pointing to her sites of disease. So multiple spots in the liver here, some of them towards the edge of the liver, the bigger one on screen left, but then scattered small spots throughout the liver in the middle panel. And then I'm not exclusively highlighting bony disease. She has many sites of bony disease, but the most conspicuous sites being in the lumbar spine and lower down in the pelvis. So she underwent a dotatate PET that showed somatostatin receptor expressing liver disease, nodal disease, bony disease, and impressive scan, as you can see here. Although Dr. Chen, maybe you can comment on the uptake in the liver metastases, which is a little bit more mixed relative to maybe the bones.
Yeah. So you can see that this is highly dotatate avid disease. Most of it is above the spleen. And even in the liver metastases, you can see that some of them are similar to the spleen than others. So that's pretty avid still. But you can see some heterogeneity. Some of it is smaller. The smaller lesions are going to not show up as well. But you can already see some heterogeneity even just looking at the largest two. So this larger one in the right liver has a lower level of uptake than this other one that's similarly sized, even though smaller. There's a suggestion of probably maybe central necrosis. There's a bit of photopenia there. And so that just highlights the fact that that reflects the more aggressive biology that they found on the pathology. And just in general, this gets to the heterogeneity that I think came up in one of the other cases as well, that you can see heterogeneous expression. And similarly, even though some of these areas are smaller, but you can see even within these disease sites, I think some of these are in ribs, there's still some heterogeneity even in the bone disease.
And I know this is technically the liver-directed therapy part of the program, but at this point, if we were to talk about this patient in tumor board, Dr. Zhen versus Dr. Chen, what would you say about systemic therapy versus PRRT at this point for this patient?
Yeah, I think, and appreciate Dr. Chen's thoughts, and I'm very well aware of this case. So I think part of it is, I think the discussions that we had here, right? So obviously, somatostatin receptor expressing disease, Lutathera makes sense because it could bind to it. But I think there's some concerns that if there are some disease that's not strongly somatostatin receptor expressing, maybe those are not going to be as responsive to Lutathera. So I think we have to have a risk-benefit discussion about, if we want to treat all of the disease, maybe systemic therapy might be better. This patient also has a large volume amount of disease, so we also don't know how quickly sometimes Lutathera may work. So then maybe if we want a faster response, we may want to do systemic therapy, right? So.
Yeah.
Perfect. Good. And then there's a very prescient question from Dr. Chiorean in the chat. So maybe we'll move on to the next slide. And advance, please. Perfect. So she, just for symptomatic relief, got palliative external beam radiation to her spine metastases, again, more for pain relief than anything else. And then, as Dr. Zhen mentioned, based off of our discussions, we started systemic therapies for her for CAPTEM, which we'll table discussion of for the moment, since this is supposed to be the liver-directed therapy portion of the talk. We did get an FDG PET. So again, looking for potentially more aggressive disease, or helping to inform decisions about what to do about sites of less somatostatin receptor avid disease. So that FDG PET did show some uptake in her two largest liver metastases, but minimal uptake elsewhere. So suggesting that those two largest liver metastases were perhaps behaving with biology that was somewhat different or more aggressive than her other sites of disease. So advance, please.
Quick
Oh,
comment.
and go ahead. Yes, please.
Yeah, you can see again, it's similar to the brain. So that indicates fairly high level FDG uptake. So just to further corroborate what Dr. Laidlaw was saying, aggressive.
Perfect. Yeah, thank you. So she started octreotide, again, based off of the fact that most of her disease was relatively somatostatin receptor expressive, and then really had an excellent response. So from the summer of 2023 through summer of 2024, really stable disease. So if you advance to the next slide, please, and advance again. So we restaged her in the summer of 2024. And overall, you can see on screen right showing the images from her DOTA tape PET between 2023 and 2024. Really nice response in the osseous or bony metastatic disease. However, there are some changes in her liver disease, and that's also reflective of on the CAT scan that I'm showing in screen left. So increasing size and increasing avidity, predominantly in those two largest liver metastases. And Dr. Chen, I know busy DOTA tape images, but anything else you'd like to comment on in those DOTA tape images?
No, those are probably, those are the biggest salient points.
Okay, perfect. So if you advance, please. Perfect. So arrows just showing really the marked progression of those two largest liver metastases. There was also increased size of an ovarian metastasis, but otherwise, really a reasonably nice response in the remainder of her dotatate avid disease. So at this point, we again sort of discussed her in our neuroendocrine tumor board, and similar situation to the last patient of, yes, we do have disease that is outside the liver. It seems to have responded relatively well to her current therapies, but she does have liver dominant progression in two spots that it looks like I could probably treat without damaging too much normal liver. And so we did have the discussion of, does it make sense to do PRRT, or should we try to do a more targeted approach just to those two areas? And decided on liver-directed therapy. I should probably give Dr. Childers a chance to address whether or not he would resect here. I don't know, Dr. Childers, if you want to comment on that.
Yeah, I think this is one of those settings where multidisciplinary conversation is like super important. The answer is that technically resectable? Yes. I think as a surgical oncologist, most of the time when I'm getting involved in patients, it's to quote unquote try to clear their disease. And this is obviously not that patient. And there's no doubt about it that what I do is probably more invasive and has a higher morbidity risk than what Dr. Laidlaw is doing. Even something like that is maybe we could probably even do a laparoscopic resection of segment 6 basically there. you're still looking at a couple of days in the hospital, about a 10-15% risk of having some sort of a surgical complication. And while there may be some marginal benefit in terms of local recurrence rates, I think that the increased risk that we're putting patients in to get that, especially if we're not going to be able to say we're fully getting rid of their disease, it's a discussion, obviously, with the patient and with our team, and we kind of come up with the best recommendation for them.
Perfect. Excellent. So ultimately, after multidisciplinary discussion, what we decided to do was treat those two enlarging liver metastases with selective Y90 radioembolization. And by selective, I mean trying to spare as much normal liver as possible, knowing that this patient is going to get other treatments down the road. So when I do Y90, I break it up into two procedures because I can't just go in there and inject radiation without a plan. I need to be very precise with my administration of that therapy. So I do first what's called a mapping procedure, where I just place a small catheter through the artery at the groin, navigate it up into the arteries that go to the liver, and take pictures, planning out exactly what arteries I'm going to need to treat. And that helps me also do dosimetry calculations for exactly how much radiation I want to administer to kill that tumor. So you can see I've sort of labeled my different treatment sites here. This patient had multiple arteries supplying these two tumors, so sort of a finicky mapping procedure, but we got great pictures and came up with a good plan. So if you can advance, please. I will say I get a CAT scan while I inject dye into these liver arteries when I'm doing these mapping procedures. And what I'm showing on screen left is her largest tumor abutting her gallbladder and sharing a little bit of blood supply with her gallbladder. So I don't want to get radiation into the gallbladder. I do have to be very careful about that. But I know that even a little radiation kind of up against the gallbladder can cause symptoms. And that'll become relevant for this patient in a few minutes. The middle bottom panel and the rightmost bottom panel show where the radiation that I administered went. So you can see it localized really nicely to the tumor that's abutting the gallbladder, as well as that tumor that was more towards the patient's back or kidney there. So great localization of radiation. I was very happy. If you go on to next slide, please. So this is how she did. So we got restaging imaging a couple of months later, which is usually what I do. You can see that her disease that was nice and bright and alive in August of 2024 is now a black hole. It is dead. I administered pretty high dose radiation here. And Dr. Chen, I don't know if you can circle the gallbladder on that sort of right image. Yeah, exactly. Yeah, perfect. So that's the gallbladder. That's the gallbladder. And it's tough if you're not a radiologist, but there is actually a little bit of gallbladder wall thickening here. So I definitely inflamed her gallbladder a little bit just by injecting radiation right next to it. If you advance the slide, please. This is the other area that we treated. So again, sort of that second from right image, you can see bright disease that is now effectively a black hole, again, pretty close to the gallbladder. So really nice imaging response. But unfortunately, she really felt the radiation to this area. And I think that's because I irritated the gallbladder with that strong radiation. So if you advance, please. She had quite a bit of right upper quadrant pain, so effectively gallbladder inflammation that did resolve after a couple of weeks with conservative management, and overall really nice response in those liver metastases, but continued to have increasing size of her untreated liver metastases as well as her lymph nodes. So advance, please. So at this point, with me having treated those areas that I could selectively get, but still with progressive disease, we had another multidisciplinary discussion. So I think, Dr. Chen, would you be able to comment on sort of the decision to move forward with PRRT for this patient at this point?
Yeah, so then we've taken care of, because the liver disease is what's most concerning in terms of determining the long-term mortality for these patients. And so that's another reason why when you have these liver lesions, even if we're considering she has a lot of extrahepatic disease. And so it's really good to try to get, if we can get better control of the disease, as you can see, Dr. Laidlaw show, you can shrink the tumors with the catheter-based liver-directed therapies. Lutathera, lutetium dotatate, and PRRT in general, those do not consistently shrink tumors. And so that's why it's nice to have a modality where you can shrink the tumors and then use the PRRT to at least stabilize the rest of it. With higher grade 3 in the NETTER-2 trial, they did show that there were higher response rates in terms terms of shrinkage of tumor more than so than NETTER-1. So the difference between those two trials was that NETTER-1 looked at lower grade, like grade 1 and grade 2 neuroendocrine tumors, and NETTER-2 looked at the, and you will hear more about it later. Actually, I shouldn't be going into it because I think Dr. Iravani is probably going to talk about that in more detail. So the bottom line is, though, the higher grade tumors was what was studied in NETTER-2. And so that was the, so, they showed responses. And so this is the justification for now having controlled the two that grew the most to then proceed to try to control the rest of the disease with Lutathera. And these are the SPECT images that we get post-treatment. So lutetium dotatate SPECT. And you can see that over time, we actually are knocking down the dotatate avidity in the liver tumor sites, which is really good. Some of these other sites are still stable. We still, even though we see some of those objective response rates, we still counsel that we're probably going to see stable disease, but we do see a nice, at least, reduction in the amount of dotatate uptake. And just to be clear, those response rates are usually by RECIST, meaning measurable disease, so like an actual anatomic shrinkage. So, but at least the SPECT, when you see this decreasing uptake, is reassuring that at least we're getting at some of these sites. Dr. Iravani, would you like to comment more on the utility of the SPECTs and how we might further interpret this for this case?
Sure. I guess I'm just a little bit vigilant that I'm not going through the break time right now. Do we have time to talk about it right now?
We can give a couple minutes. So yep.
Yes, couple
Oh,
minutes.
sorry. Okay.
Yeah, I think this is something that's I think I'll probably going to be touching as well in our case, more advanced cases. But this is one of the kind of the specific things about our practice, which we do post-treatment imaging, because obviously the lutetium-177 is imageable. And we do the imaging 24 hours after each treatment. And as you can see, it's a very useful imaging. It's kind of creates similar imaging to PET with lower resolution, obviously. But we generally use it for response assessment, as you see in this case in the liver. But at the same time, also you see the area of disease which may be resistant to treatment. For instance, the ovarian mass that the patient had, and we see kind of persisted over time and maybe even become more prominent. But it basically directs our treatment and responses, and it's very useful imaging modality.
Thank you. Well, I apologize. That's my fault. I think I got mixed up when the break and when the session ended.
No worries.
Perfect. Well, in this case, I think we'll be wrapping up relatively quickly. I think just going through sort of the remainder of this patient's course, like Dr. Chen said, she had an outstanding response to PRRT. Dr. Iravani and Dr. Chen both mentioned she did still have residual viable disease in the ovary or the adnexa. And so actually went on to resection of that, which showed slightly different pathology results than sort of her original liver biopsy. So high-grade neuroendocrine carcinoma, but otherwise a really nice response to PRRT. Unfortunately, she eventually did progress. This is recent imaging showing intracranial metastases, bony metastases. There is some recurrent disease in the liver as well. And so we've moved on to additional systemic therapies for her at this time, knowing that there may still be additional options for potentially, depending on how she does, additional liver-directed therapy or other therapies. So that's all I have to say about this case. I don't know if Dr. Chen or Dr. Zhen or others want to chime in, but I appreciate the time.
Yeah, no, thank you so much. And Dr. Laidlaw, I forgot that you had a fourth case, so my apologies if I was taking a lot of time. But
That's
and I
okay.
know there's some other questions we can kind of address later, but I think just for the sake of time, I know we're in the middle of our break. So first, I'd like to thank Doctors Chen, Laidlaw, and Childers for joining today. Just for you aware, Doctors Laidlaw and Dr. Childers are on call this weekend, so we will release them to their clinical duties for the weekend. But if there's any questions, happy to answer along through the conference. So, all right, with that, I will give a 10-minute break. So we will adjourn back and we'll come back at 10:10. So I hope you had a good break. We will go ahead and resume now the second half portion of our event today. And we'll start off with the second half with a introduction both by the co-chairs of the Pacific Northwest Neuroendocrine Cancer Group, Denny and Gary. So Denny and Gary, take it on.
All right, thanks, David. I'll kick off here and just say Happy Valentine's to everybody, and it's great to have so many patients and caregivers with us. I know some of you are going to see this recording later, but we're glad to have everybody signed up that's joined. It's a nice sized group today. First, I'd just like to thank the doctors from Fred Hutch and UW that are with us today and giving their time and expertise. And the first half has just been amazing. Not only all the content, which I'm going to have to go back to look at again later, just to gather it all up, but also the live interaction that we're having is just incredible to have an opportunity to do that. So thanks to David for organizing that and having that kind of interaction available to us. Also, Alana and the team at the Medical Education and Outreach Group at Fed Hutch for doing this. A lot of work in the background to make this happen. And David said this is the second time we've had a symposium, but it's actually the third time, because we had a mini symposium before the full-blown one a couple of years ago, and we hope we can continue to do this with your support at least every 2 years. So it's great to have this opportunity. Finally, a special thanks to Dr. Zhen and Chen and Iravani. You all are, as co-chairs for all of us, are the heart of the NET program at Fred Hutch, and we're just so grateful to have you here in the Pacific Northwest to be available to all of us that do receive your care. A quick overview of the Pacific Northwest Cancer Support Group here. We were founded in 2006 to help connect and educate NET cancer patients in our area, and we continue to grow. A little bit, and I think our slide is up. I can't see it, David, but
Alana, are you able to pull it up, or do you want me to share? Great.
So everyone will get this in their slides, so you don't have to write this down, but there's links, etc. With this. So typically we hold quarterly Zoom meetings and one in-person meeting a year. Thank you, Natalie, for organizing that this last year, and we hope to continue that on an annual basis. We've got a couple main ways we communicate with each other. One is our private Facebook group. There's a link here, and the other is our Pacific Northwest listserv. And there's contacts there for Karn and Gary to get signed up for that. Some people prefer the listserv, some people prefer communicating on Facebook. Either one works, and you can reach us, the leadership team, via either format, and we'll respond. There's a website, and I have a note here. We'd love to have someone help us update this because it hasn't been updated in format in years, and it'd be good to have that. So there is a website for us, and it's linked there. And thanks again to the leadership team, Gary, me, Karn, Megan Hendrickson, and Natalie Santos for all the work that we do and they do to help organize this for us. And I also have a shout out to the other West Coast support groups and resources that are out there for us. And these are all friends along the West Coast. And as they've welcomed me into their groups, we welcome them into our groups. And I know we've got people from all up and down the coast in attendance today. So up in mainland British Columbia, we've got our friends in Canada. Karen runs a great support group up there. In Portland, Bert Rosen and the PDX Network group down there. He's got a Facebook page, also a Adventures in Nets Facebook page that they run out of there. Northern California, many of you know Josh Mailman. He's a strong friend and supporter with us here in the Northwest. And he has a twice a week support group down there, and also lots of information and a ton of expertise that we all rely on. And then in Southern California, Lisa and Heather have the NCF group down there. And many of us are also involved with Lisa and Heather. I'm what's called a Net Connect peer-to-peer participant, helping cancer patients outside of the support group with just a chance for one-on-one discussions or answering questions from my perspective and my experience, as if they'll help other patients as well. And I know Gary and I and others in the Pacific Northwest do that as well for our members up here. And just the NCF, many of you know about it, but they have just a treasure trove of resources and content and videos and podcasts. So, and those are available to everybody free of charge. They're just amazing. I'll pass it off to Gary. What else you want to add, Gary? Gary's been with us for much longer in the support group than I have. He has a longer journey. I've got about 6 years, and Gary's been on this path a lot of years.
Yeah, I actually found this support group about 2 weeks after I was diagnosed, and that was back in 2008. And this group was formed in 2006. So I've seen a lot of changes and developments over the year, but one of the biggest opportunities for us was the collaboration with Fred Hutch on these presentations. And I want to also say this isn't a one-way street with just presentations from Fred Hutch. We try to reciprocate in a different way, and that is we have team members who have support group members who have formed teams for the Obliteride, the big fundraiser for Fred Hutch. And we will be doing this again in the spring when information begins to come out on Obliteride. And for 2025, members of our group were responsible for donations of close to $20,000, which were designated for net cancer research at Fred Hutch. So we try to do our part, and Fred Hutch has done more than their part in being able to provide us being the net community with information such as you're all receiving today, and we greatly appreciate it. And that's about it from my part. It's really been a great plus to have Fred Hutch involved in our ability to communicate important information to the net community. Thank you.
Thank you so much, Gary and Denny. And I just also want to state that what you guys do is just fantastic. Obviously, we the physicians, we care for the patients, but that's not the only thing about their cancers and treatments. And as you know, you've gone through the personal journeys and a lot that goes through that, both physical but also psychological. And so I think you provide a very, very significant support for our patients. I really want to thank you guys for what you're doing. So. All right. Well, with that, thank you very much. And I think we're going to move on to our second tumor board of the conference. And so this is really focusing on how we make some decisions about systemic therapies, more specifically about radioligand therapy against other treatments. And here I'm pleased to have Dr. Chiorean, who's the lead of our GI oncology group, also sees many of our neuroendocrine patients along with me. Dr. Fogh, who's our integrative oncology, and she's going to help provide a perspective. I know there's a lot of interest about how integrative oncology, integrative medicine can support the cancer treatments for neuroendocrine patients. And then Dr. Iravani, who will be leading the radiology discussion. So Dr. Iravani, I will let you go ahead and start the session. So.
Thank you very much, Dr. Zhen, and thanks for our other panelists that so far we've had an outstanding presentations and discussions so far. This is I'll be presenting the cases and discussing with Dr. Chiorean and Dr. Fogh about the now moving to more a systemic treatment for these patients for the neuroendocrine tumor. It's a very important topic because now with the increasing number of available treatments and the clinical trial reading out in favor of different treatments, so it's very important to understand how we're going to sequence the treatment and the role of multidisciplinary team meetings, which is still very kind of emphasized by the NCCN as Dr. Zhen is on the panel, which it's basically now with increasing treatments, it's personalizing treatments, and multidisciplinary discussion is as of utmost importance. So I'm just going to be sharing my slides here. I'm hoping I'm sharing the correct screen.
We see that, Dr. Iravani.
Very good. Okay, so starting with the case one. So it's a 73-year-old patient with an incidental findings of upper abdominal masses. It was incidentally found after a motor vehicle accident a few years ago. When they did kind of trauma imaging, they noticed a couple of large masses in the upper abdomen measuring up to 7 centimeter, another one up to 6 centimeter. Very surprisingly, the patient were asymptomatic in relation to these masses. And also at the same time, they noted that there are multiple liver lesions and we're suspecting metastatic disease. So the patient went on to have CT-guided biopsy of the lesions, and it turns out to be well-differentiated neuroendocrine tumor, Ki67 of 1%. And immunohistochemistry, there are some other tests that can be done on the histopathology to see and delineate the primary site of disease, but it was not specific for a primary site. At the same time, the patient's functional status was very well, was excellent, fully functional, independent. There was no evidence of carcinoid syndrome symptoms like these patients may have. And also there was limited comorbidities in terms of other medical conditions, apart from a couple of medical, non-significant medical history. So these are the imaging of the patients. This is the trauma imaging that the patient has. This is not a dedicated imaging. So this is a venous phase contrast. You see this large mass here. It's kind of embodying the major vessels in the abdomen. And this is when the patient went on to have the dedicated imaging. We see again this large mass now better delineated in a kind of a more arterial phase of the imaging. You see on the arterial phase and a slightly delayed imaging. And this is large mass and multiple liver lesions. What I'm going to show that how kind of importance to have the dedicated imaging for neuroendocrine tumors, as you see, for instance, the liver lesions, which are relatively well delineated and not quite obvious on the prior image, become very well delineated. And a slightly delayed phase of the venous, we see they are becoming a little bit less distinct and kind of becoming like these two lesions become almost one lesion, kind of bilobe lesion. So that's importance of the imaging. I open it to discussion. Dr. Chiorean, please, and Dr. Fogh, if you have any other comments about the imaging of this patient.
I just wanted to say I obviously I don't know this patient, but there is very burdensome level of disease in the liver. Do we think that this may have been a primary in the bowel, or where do we think the primary originated in this case?
It's a great question. And also it's obviously open to all the panelists to comment on this. So yeah, the lesions are part, I mean, I'm not showing all the lesions, but I can kind of describe what has been shown on the CT. It seems to be in the upper abdomen, and it was separate from the pancreas, although it was close to the pancreas, the two abdominal masses, and there was the CT didn't show any lesion in the small bowel. I guess this is the more kind of most common sites of a primary for a neuroendocrine tumor. And I think it kind of been touched on the previous case presentation that there are a subset of patients which we don't find the primary site of disease. So the patient went on to have a dotatate PET scan, which we saw a few of them in the last presentation. And we see the large masses in the upper abdomen. This is one of them here, has a very high uptake. And also another mass here separately, slightly more anteriorly. Here as well is very intensely avid. And a pretty extensive liver lesions here, highly avid. And as Dr. Chen kind of in the previous presentation presented that we use the organs of reference in the dotatate PET scan versus TR PET scan, which are liver and spleen, and particularly the spleen. When it's above the spleen, it means that there's a very high expression of somatostatin receptors in the tumors. Any other comments, Dr. Chiorean, about the imaging and potentially other workups that the patient have and potential options and considerations for this patient?
I think that the site of origin is meaningful. We see some very bulky disease in the portal-caval space, and again, looking at the symptomatology of the patient, do we have any symptoms of gastric outlet obstruction, nausea, vomiting? Sometimes an endoscopy may be important. Again, we look at the patient's symptoms to determine, do we think about any peptic ulcer disease symptoms, dyspepsia? So other workup really depends on the clinical scenario and may involve an endoscopic approach. But I think that the CT scan, dual phase, and DOTA PET CT, together with blood work, including, comprehensive blood panel, we oftentimes do get chromogranin A levels, serotonin levels, just as a baseline, and occasionally we monitor, but it depends again on the levels. We all know that they are very subjective to different foods, different medications often. But that's, again, the workup really depends on the patient's symptoms as well as the national guidelines staging standards.
And I would also, say, I don't know if we have any tissue yet, so I probably would like some pathology on grade and such like that. And then going back to Dr. Chiorean's point about symptoms, right, whether from the tumor or even functional symptoms. And I think this is where I think, depending on how this presentation goes and such like that, I think that's where I might involve Dr. Fogh to think about other avenues besides our medical treatments, right, that we can support our patients through that symptomatic journey. So.
I see a CT-guided biopsy was done with a Ki-67 index of 1%.
Oh, sorry if I missed that.
I assume, I don't know, that was a liver or it was something else that was biopsied.
It was a liver biopsy.
Okay.
And I guess, Dr. Fogh, if you have any other comments so far?
No, I think just depending on what both the patient's symptoms look like now and what the treatment plan is and what symptoms might be expected from that treatment plan would really customize how we thought about integrative approaches, which certainly wouldn't replace any conventional treatment, but are really designed to be supportive of the treatment and the symptoms.
Right.
It looks like it started out as an incidental finding, so
right.
That this was a motor vehicle accident, and imaging scans revealed this burdensome disease, but the patient may have actually not had any symptoms. Yeah, this is quite interesting.
Right.
We know that it takes an average of 9 to 10 years of patients having vague symptoms of oftentimes irritable bowel syndrome or vague, flushing one in a blue moon. So it's possible that patients are completely asymptomatic for a long time before diagnosis. It's not unusual. And I think that the symptomatology really also is very informative in terms of how aggressive the treatment options we want to pursue it and so forth.
I think that's very important. So I think you've kind of alluded to that we put the patient symptoms in different buckets. So one bucket is the symptoms as related to the hormone excess or functional symptoms. As Dr. Zhen also mentioned, there are some symptoms related to the volume of the disease and burden of the disease, and particularly other symptoms related to where the lesions are in critical organs or causing mechanical obstruction in different organs, particularly the bowel or kidneys or other things that kind of considered for treatment options. So just a little bit follow up on this patient. So this patient in 2018 was diagnosed, and then we had The patient went kind of, was coming to our service and then out of our service. So in 2022, had another PET scan. So decided to kind of being conservatively manage at this stage with the somatostatin analogs as the first-line treatment for the patients, and went on to have another imaging in 4 years when he came back for second opinion again in our center. And so we see the dotatate PET scans. I see Dr. Chen is also online. Would you comment on the scans and see, do you see any difference between the scans, or how do you interpret?
Oh, yeah. I mean, overall, just looking at the MIP images, which are on the very left and very right of the screen, the overall disease burden looks very similar. And you see the spleen difference again. So I assume they started a somatostatin analog, I assume in between. But overall, the disease burden looks fairly similar to me. Just looking.
Right. So, so the patient again was presented at multidisciplinary meetings, and the patient remains on somatostatin analogs with relatively low burden of the symptoms. The patient kind of described some diarrhea initially after each injection of the somatostatin analogs, but then a few days later it would improve, and the patient remains asymptomatic during the course of the 1 month injections. So the same thing's kind of been repeated, and over time it's become less apparent after multiple injections, those initial diarrhea that the patient had. So any change in the patient? So the patient's coming for the second opinion. Would you consider Dr. Chiorean or for any change in the patient management? You're muted, Dr. Chiorean.
If the patient hasn't had yet an upper endoscopy, an endoscopic ultrasound to really evaluate the duodenum, the antrum of the stomach, pancreatic head area, again, I don't think that there is anything wrong with the pancreas, but I would have loved to have at least this endoscopic evaluation to give us a better look. But in my opinion, the fact that the patient remains asymptomatic with minimal treatment-related symptoms, actually, it's extremely encouraging. And oftentimes, we know that, yes, we can start with somatostatin analog, an asymptomatic patient, but actually a period of observation without somatostatin analog can also be considered for completely asymptomatic patients. Just because, as you pointed out, SSAs are not devoid of side effects, and certainly inconvenience, having to go to a clinic to get injections every 4 weeks. The burden of disease, to me, I would have preferred this patient indeed to start with SSA because I would be concerned about the burden, the liver metastasis burden. But if it wasn't this burdensome, an asymptomatic patient found incidentally, let's say, to have maybe less burden of disease, monitoring off any treatment is very acceptable and keeping a close eye. So to date, other than an upper endoscopy to make sure I do due diligence, I think that the patient has been managed very well.
Right.
Oh, sorry, go ahead.
Please.
I'll just add from an integrative medicine perspective, we always think about where the patients are at treatment. And it's interesting because with that burden of disease in the liver and other cancer sites, that patient would likely be very symptomatic. And then we would be focusing on making sure we're not losing weight and, going towards a cachectic picture. We really are thinking about where the patients are. And somebody who is feeling well, not having a lot of symptoms, this is the optimal time to making sure we're getting good movement or exercise. That's been shown across all cancers and in our NETs to have benefit on not just symptoms, but outcomes and survival, and making sure that nutrition is optimized, making sure we are incorporating our mind-body approaches, which are known to help with stress resilience and improve quality of life. So this is a great time to be thinking about how those can be incorporated while somebody's feeling and not having a lot of symptoms.
It's a very great point, actually, because this disease is so insidious that we sometimes see the patients, every time we see the patient, patients say that they're feeling excellent and no change in the symptoms. When we looked at the chart, we see that progressively the patient's losing weight. After each treatment, after each kind of visits. So I guess it's very important that you're mentioning this.
Yes, absolutely, because there is so much online out there that sugars are bad for cancer and these disease states. And so patients are trying to follow really strict ketogenic fasting approaches. We do have to keep an eye on that weight, that muscle mass. That's actually a marker of our functional status. When we have our weight in a good place, we do want to have good metabolic health. But we also want to make sure that patients aren't losing muscle mass, losing balance, losing the ability, their functional status as they're going through these treatments.
I actually do have a comment and a question for Dr. Fogh. In many cancers outside of neuroendocrine, we hear for breast, colorectal, ovarian, that GLP-1 inhibitors are actually recommended and may actually improve cancer outcomes due to the reduction in fat in the body. What is your take and potential concern that, in fact, this may not be the case in neuroendocrine tumors? Do we know a lot or enough at this point to make a recommendation regarding the GLP-1 inhibitors to our patients with neuroendocrine cancers?
It's interesting. I know there are some studies that are coming out in other types of cancers, but they're very early right now. And so what I would say is the big umbrella overview is good metabolic health is good for most cancers. Not having insulin resistance, which downstream insulin like growth factor, having good healthy microbiomes, not having sort of visceral fat, which can be inflammatory and can actually be estrogenic in some cancers, which isn't a good thing. The GLP-1s are interesting because they are turning off the food noise, and we don't actually want that for all of our patients. So I think it's really important. And then some actually are known to more preserve muscle mass than others. There's a lot we really need to figure out. It has not been studied in this type of tumor. I think that metabolic health is an area we really want to focus on with all of these areas, but we have to be careful. If I treat patients with primary brain tumors, if I have somebody who is, going towards a cachectic state, and then I give them a GLP-1, and that really turns off any food noise. It's interesting in the brain tumor space with ketogenic diets, about 50% of patients actually have to come off trial. But that may be a good thing. There may be situations where we don't want patients not eating or losing weight at this rate. So it really needs to be individualized.
Yeah, I would take one step back. I know there's a lot of questions in the chat right now, and we'll come back to those for you, Dr. Fogh. But there was coming back on the GLP-1, I think there was a valid question about what is a GLP-1. So GLP-1 are basically these new agents that are targeting against this target called GLP-1, and it's used for the treatment of diabetes. But GLP-1 is also a target that if we're using those drugs for diabetes, there's a theoretical risk that this may be a way that we could cause neuroendocrine tumors to grow. Again, a theoretical concern. I don't think it's been validated, and I agree with Dr. Fogh that the data is pretty limited right now. I will say at the last North American Neuroendocrine Tumor Society meeting, NANETS, this past November, the University of Iowa, who's like a very big powerhouse of neuroendocrine tumors, they basically had some preclinical studies, again, in like animals and everything like that to suggest that it might grow. But they actually have a NIH-funded grant and SPORE right now that they're actually going to do a prospective study in patients and everything to better understand that. So more to come, data on that, but we just don't have enough data on that yet. So.
And I'm also curious, one other questions which in this case might be related to this case and other cases is one of the complications of the neuroendocrine tumor is a carcinoid heart disease, and particularly with the patient with a larger volume of disease, and we see that. I'm curious to know, how do you kind of risk stratify patients, and how would you investigate the patients have or may develop carcinoid heart disease, at what stage you would be suspecting, and what investigation you would do.
Yeah, I think from the carcinoid heart disease standpoint, this is all also over the place, and I think there's been a lot more studies presented at recent conferences about understanding the incidence and prevalence, because as much as we've known about this for a long time, we actually still don't really truly know that. But we usually say maybe somewhere around the range of up to 20-30% of patients have this. The question is how to identify it. I think many people have talked about that's why we do some of these baseline hormone markers. So, for example, the 24-hour 5-HIA, right, which urine 5-HIA, which we use as a marker for serotonin production and i.e. carcinoid syndrome. The idea is that if they're already producing serotonin, they might be higher risk, and it might lend you to doing one baseline echo, echocardiogram or an ultrasound of your heart to see if there is evidence of basically carcinoid heart disease. And then obviously, if a patient actually has active symptoms on exam, right, symptoms of heart failure or murmur on their cardiac exam, that would also be the indication that we would have to screen. So,
right. And as you mentioned, it's very important to kind of be proactive and detect this complication because it has important ramification for the patient. So the patient again was kind of every year was coming back to multidisciplinary meetings, and I'm just going to show the different imaging here. Again, coming back in 2023, the patient had another dotatate PET scan. I think one of the questions as well in the previous case presentation was how often are we using dotatate PET for surveillance of the patient? So this patient, obviously, I mean, interestingly, the patient had almost every year had a dotatate PET scan. And this is in 2023, then 2024, and then 2025. And every time it's coming back, just recently as well, had a dotatate PET scan in 2025, remained on somatostatin analog and the same treatment during whole time. And again, presented in 2025. And I'm just going to add Dr. Chen again to comment on the dotatate PET over the years.
Yeah, there are not dramatic changes to my eye. So looking at the MIP, usually when I'm looking at these, I will look at the cross-sectional imaging, of course, to try to do a somewhat lesion by lesion comparison, which is always challenging when they have this many liver tumors. But that said, just looking at the MIPs themselves, I'm not seeing really large changes. As I mentioned, some of the lesions seem to have had decreased uptake a little bit over time, maybe increased, but very small changes. Oh, thank you.
Making it easier for you.
Yeah, thank you.
Yeah, so the left panel is 2018 at the baseline, and the middle is 2023, and the right side is 2025.
Yeah, thank you. So this is where I was wondering about the potential confluence of the on the very 2025. So it's always hard to tell in those MIPS, but I do think this shows a little bit some of the changes, and we in the importance of having the anatomic imaging with the dotatate PET. In the central liver, you can see that there is this hypodense lesion that seems more apparent as you go in over time. At the same time, though, the size doesn't seem to have changed very much. You see a little bit of more hypodensity in the 20, you said the right was the 2025 scan?
Right.
Yeah. So if you see that those largest hypodense lesions in the middle, there is you can see a little more hypodensity above it. So I just wonder if there might be some new lesions, like new small lesions that are cropping up over time. But otherwise, again, not dramatic changes in the extent of disease or the somatostatin expression levels.
Yes, right. And I guess I have a question for Dr. Chiorean and Dr. Zhen before. So in these cases, when the patient have only dotatate PET, would you complement this with the other type of imaging as well? Like how much you kind of put your weight on structural imaging, like for instance, CT or MR, and how much on the dotatate PET in kind of making a decision whether the patient in fact is stable or maybe minimally progressive?
Yeah, so first of all, I personally like to follow the anatomical distribution of the lesions with CT scans with dual phase or triple phase contrast for the patients. and obtain functional DOTA PET scans periodically. So if somebody has stable imaging, has stable symptoms, initially I start with every 3 months scans, I go to 6 months and then yearly scans. For a stable patient like this, DOTA PET scans are generally done every 2 to 3 years. We don't do DOTA PET scans every 3 months, 6 months, yearly, etc. So if the CT scans, if the anatomic CT scan shows me a new lesion, or if the patient has new symptoms, which I can't explain with the CT scan, absolutely, I would obtain a new DOTA PET scan sooner than every 2 to 3 years. So generally, patients, if they're doing well, they are asymptomatic. We have them come in every 4 weeks for their somatostatin analogs. Imaging goes initially a little bit more frequently, every 3 to 4 months, but then I stretch it to 6, stretch it to 12, according to national guidelines. And the DOTA PET scans come in about every 2 to 3 years if all is good. And more frequently, if we see new lesions, something that we can't explain, or if the symptoms that the patients have cannot be fully explained by the CT scan. Or let's say I may get a marker like a chromogranin A or a serotonin level that is overly high, cannot explain it, and then I would get a new functional DOTA PET scan.
Yeah, I would agree with Dr. Chiorean on a lot of those points, and how I kind of explain it to patients, right? Each scan serves a different purpose and serves a different question you're trying to answer, right? In general, if we want to know if cancer is progressing, right, the definition is either growth of spots or new spots, right? So part of it is just like Dr. Chiorean mentioned. Sometimes if, let's say, a patient is having a lot of symptoms, but the CT saying, well, nothing's grown, nothing's new, I'm a little bit concerned if I might be missing something that I don't see. And so, yes, a dotatate PET scan would be helpful there. The other reason I might do another dotatate PET scan would be to affect treatment options, right? So if I want to decide that a patient might be a candidate for PRRT with Lutathera, I also want to make sure that their tumors are all making somatostatin receptor expression. So I would also get a dotatate PET to help confirm that, to dictate treatment options. But for the most part, yeah, I would agree that following with anatomical imaging, a good CT or MRI with multi-phase contrast, yep, is the best. So
yeah, wonderful. So the one question I had here is, so with the, I mean, we don't, the NETTER-1 kind of established PRRT as the treatment for patient with the progressive G1 and G2 neuroendocrine tumor, and NETTER-2 made it an upfront treatment for patients. So they did not necessarily need to have progressive disease, but in more kind of a higher grade disease, K6 or 7, 10% and above. And Dr. Zhen, you were also in NCCN guidelines, and the NCCN was updated last year, and so bringing PRRT as an upfront treatment. So when would you consider an upfront PRRT, which was for these patients, or what are the factors you consider with now availability of PRRT as an upfront treatment in these patients?
yeah, I think if I was to base it off on, like, do I have a definitive study to really have defined criteria that's based on strong data? No, I think a lot of those guidelines that were developed from the NCCN and everything is a lot of like clinical practice and what's our gestalt, right? Because I think part of it is, I think there is data that moving PRRT earlier might be beneficial, but at the same token too, like if it's a newly diagnosed patient, somatostatin analogs are pretty well tolerated, right? And aside from doing the injection, Lutathera generally well tolerated, but there might be some long-term effects related to that in terms of cytopenias, MDS, leukemia risk, and such like that. So it's a risk-benefit ratio, because we also have to think about these patients' journeys can be a long period of time. So we have to think about, do we need to do these treatments really quickly? But to come back to your question about when I might do upfront Lutathera, I think if it's a patient who I worry about certain side effects related to systemic therapies, right? Other targeted agents, pills, they have their own kind of side effects, but I still want some sort of response, meaning shrinkage, because I'm worried about how much cancer is there, and I'm not comfortable just waiting and such like that, or having a lot of symptoms, and I really need to shrink those tumors down to help their quality of life. that might be a situation in those instances where I might consider upfront Lutathera. But
I agree with that as well.
Very good. Okay, if there's no other comments, I can move on to the next case.
Before then, Amir, there is a question about how many rounds of PRRT can a person have over their lifetime? From the medical oncologist perspective, what we know in practice is that we are able to safely do at least 6 for patients that had, an original a PRRT which involves 4 infusions. There are now clinical trials, and we know it's safe to add at least an additional 2. I just don't know, and I would love Dr. Iravani to say what would be a maximum. Have you ever seen more than 6 safely done? And I assume it may be depending on the interval between when the first round of Lutathera has been conducted versus subsequent sessions.
And I don't think we know how many cycles the patient can tolerate, and each patient is different as well. And there's a lot of kind of other comorbidities and also genetic factors involved as well. So the current kind of label allows us to give 4 treatments, 4 cycles, but then we're retreating patients off label as well, based on some retrospective and kind of some registry data that we have. Currently, there is a phase 2 trial as well, which is comparing retreatment with 2 cycles with the everolimus, kind of a cooperative group that's happening right now. There are alpha PRRT is given post lutetium-based PRRT as well, which is also in the clinical trials, and hopefully that trial has completed recruitment, and we're waiting for the results. Yeah, it's unclear, and it's based case to case. But I've seen patients receiving even more than 6, and they tolerated treatment. But it's a matter as well whether the patient responded well to the initial course. They had a durable response initially. The biology remains the same, and the patient did not have any significant toxicity.
yeah, and that definition is probably going to change, right? And we'll discuss this in the clinical trial session, but we have the next generation of PRRT with alpha emitters, which we'll discuss. But yeah, I think that definition of how many cycles you're going to get is probably, it's very fluid right now. So
yeah. Very good. So moving to the case 2. So this is again a very long history of a patient that had a neuroendocrine tumor. So in 2007, again, this is an outside presentation. It was in the age that we didn't have many advanced imaging, probably at least in the US. So the patient presented with severe rash and worked up. It was a particular rash, which I guess Dr. Chiorean can talk about it, but which they were concerned. And then they kind of the workup for the patients, including the anatomical imaging, showed a pancreatic tail lesion. It was biopsied and then resected at the same time with a splenectomy, and the IHC immunohistochemistry basically showed a glucagon positive staining on the tumor samples, kind of consistent with the glucagonoma, is a functional tumor of the pancreas, and it was a well-differentiated neuroendocrine tumor. Ki67 was 1%. The patient again had follow-ups after that, deemed to be kind of under surveillance. In 2011, rash reappeared. There was a high glucagon level serum tests, and there was local recurrence on the anatomical imaging in the pancreatic tail region. So the patient underwent another exploratory laparotomy. They had adhesionolysis and resection of the pancreatic recurrence lesion. This time, the pathology was a little bit higher grade, and with the Ki67 of 8%. So I guess one question actually was actually mentioned as well. There is sometimes we see that the grade of the disease changes, and I think Dr. Zhen also mentioned about that we see that. So the follow-up, the patient developed liver metastasis in 2014. And at the time, the long-acting somatostatin analogs started, and the disease progressed. And in 2017 to 20, the patients recruited to a clinical trial receiving sorafenib, and I leave it to Dr. Chiorean to talk about these treatments that the patient had, the sorafenib, and then liver-directed treatment and everolimus in 2020.
Yeah, so I can say that this is my patient who actually has been diagnosed and treated in China. From diagnosis in 2007, when the rash started and everything. Surufatinib is an anti-angiogenic agent. I would say is in a way similar with cabozantinib, let's say, which is available in the United States. It's not available in the US, it's available in China. And she was treated with this treatment, part of a clinical trial. So a lot of the, images and history that happened prior to 2024, 2025 has been based on medical records and the patient recollection.
So moving ahead, so 2022 to 2023, the patients received chemotherapy with capecitabine and temozolomide, received 14 cycles along with the long-acting somatostatin analogs. And the treatment after 14 cycles was stopped in July 2023 due to disease progression. So the liver was again biopsied at this time, and this time is Ki67 of 30%. And the patient moved on to the second-line chemotherapy with FOLFOX and bevacizumab with 8 cycles, and then again re-challenged with sorafenib. I get back to Dr. Chiorean. What do you think about this sequence of treatment and the change in the grade of the disease?
Yeah, so it's very common, unfortunately, when cancer progresses, when a neuroendocrine cancer progresses, we always worry about did the tumor de-differentiate? Did it become more aggressive? Did it become a carcinoma instead of remaining a well-differentiated tumor? So it's very, very common. That's why we do repeat the DOTA PET scans, and sometimes we add FDG PETs because the DOTA PET looks at a well-differentiated tumor, the FDG PET looks at a poorly differentiated tumor, and in addition, we like to biopsy the disease to ensure that it remains well-differentiated. Treatments with capecitabine. So for pancreatic neuroendocrine tumors, we have national guidelines that tell us that capecitabine temozolomide leads to response rates of about 40 to 50%. In fact, in my opinion, is one of the best treatment-inducing shrinkage in pancreatic neuroendocrine tumor. Doesn't work quite as well in gut neuroendocrine tumors, unfortunately, and we are studying it in lung neuroendocrine tumors. FOLFOX, which is a regimen often used in gastric cancers, in small bowel cancers, in colon cancers, it absolutely can work in neuroendocrine tumors. The Stanford group, George Fisher and Dr. Pamela Kuntz, had studied FOLFOX and CAPOX with and without bevacizumab, and we do see some benefit. So this type of chemotherapy is one of the standards in neuroendocrine tumors. And as I said before, anti-angiogenic therapies, we know that these tumors are very angiogenic, very vascular. They look angiogenic even on scans because they look very white and well perfused. Angiogenic inhibitors make a lot of sense. So again, as a cancer grows, we go from one line to the next to the next. So the sequence of CAPTEM followed by FOLFOX followed by anti-angiogenic is very natural. This is what we oftentimes also considered in the US. And oftentimes we consider a chemotherapy regimen when we think the tumor is a little bit more aggressive and maybe more of an mTOR inhibitor, anti-angiogenic agent when it's a lower grade. Having said that, we know that, again, cabozantinib has good results across the board as long as a tumor is well differentiated. So again, your question was, is this sequence appropriate? Do we think it's feasible? It's something that absolutely we consider in our day-to-day practice.
Right. I guess one question to Dr. Fogh. So these patients are coming with the functional pancreatic neuroendocrine tumors, and they have over excess of hormones like glucagon, some other hormones, as there are multiple other hormones as well. And these are patients that can cause diabetes and uncontrolled diabetes as well in this patient as a complication of the disease. Obviously, we're trying to tackle the trees oncologically, but how other symptoms can be managed, and what are the effective treatments for other complications with excess hormones? You're muted, Dr. Fogh.
Sorry, is the question about treatments for metabolic syndrome or the other side effects that can come about from the FOLFOX and bevacizumab?
We could touch on both.
Okay. I think with the, any time that we're looking at metabolic syndrome, we want to incorporate not only our conventional options, metformin, having them be evaluated, seeing does a GLP-1 make sense, not to discount any of those types of treatments. Then what can we do through nutrition and exercise? How do we bring those together? The trouble is that on some of these therapies with the FOLFOX and bevacizumab, this is a time where patients can get some significant symptoms. So GI toxicity probably being pretty common, patients getting diarrhea, having nausea, vomiting, not the time to be saying, hey, we really want you to be incorporating a whole food plant-based diet. This is actually a time where I would like them connected with medical nutrition, making sure we're not having that weight loss. And that they're supported, because to help those symptoms, it may be the opposite nutrition approach that we would look at as something that would be helpful metabolically. Other symptoms that people can experience, neuropathy, from integrative approaches, getting good movement, and that's going to help with circulation, making sure their B vitamin levels are in a good place, vitamin D is checked. Acupuncture can be really helpful for neuropathy and frankly for many of these symptoms, including fatigue. Fatigue can also be helped with movement and exercise. So I think a lot of those things can help with metabolic health, but at the same time, if somebody's barely able to keep anything down, it's really not the time we're telling them to not have a lot of carbohydrates, or we want to be managing that GI toxicity as well.
And what is your suggestion about connecting the patient early with the integrative medicine?
Yeah, absolutely. So I think that's so important, because the symptoms can change, the treatment trajectory can change. We see patients everywhere from right when they're diagnosed through treatment, beyond into survivorship. And there's no wrong time for us to be working with patients. When we mentioned the other case, that was such an optimal time to be really thinking about how to optimize nutrition, exercise, mind-body practices. But we have a lot of things that we can be doing to help with this time during treatment. And if there's something we can do that does help with these symptoms, and that actually helps patients remain on the treatment, that's going to be leading to better outcomes for the patient. So we're here at all stages of the treatment trajectory.
Thank you. So moving ahead, so at this time, the patients transferred care to Fred Hutch and had another liver biopsy, which this time showed Ki67 of 40% with P53 positive. And we see this imaging here. At this time point, so the patient's been brought up to multidisciplinary team discussion with Dr. Chiorean. So I guess what treatment option we have here to offer to the patient, I guess. Dr. Chen, Dr. Zhen, or Dr. Chiorean can comment.
Yeah, so she came to join her daughter in Seattle in 2024 and was experiencing very significant abdominal pain at the time. I have never witnessed the glucagonoma rash. She has not experienced those rashes since moving to the US 2 years ago, but abdominal pain, clinical deterioration from the point of view of significant fatigue, not eating well, and we thought this was all related to burden of disease. So she was having active cancer progression in 2024.
And treatment options?
So treatment options are always, we discuss, as you very well know, in our every 2 weeks neuroendocrine tumor boards, we look at the prior treatment options, the best response to treatment options. We always consider recycling, say, a previous treatment if we think that the benefit from the prior treatment was at least 12 months, if not longer. And our tumor board recommendation in the setting of, I don't know if we have all the images, but she had extrahepatic disease, she had nodal disease, she had, I believe, some bone metastases. So we recommended PRRT upon this more recent progression.
Yeah, and just mentioning, as you mentioned, that this is a nodal disease outside of the liver, so that's we see it as well, and see we feel bone lesions, as you stated. So there are extrahepatic disease as well.
And I think this is important when we look and analyze every patient in a tumor board. We look at, is there progression in extrahepatic sites? Because we, as Dr. Laidlaw pointed out in the previous session, if there is a dominant progression just in the liver, sometimes we choose to consider liver-directed therapy. But if we do see systemic progression, and in this case, we thought that she had systemic progression, we oftentimes consider systemic therapies as a best approach.
Right. Dr. Chen, do you think this is a PRRT is a good option for this patient?
Yeah, so I mean, I think it may be less effective when it's like liver dominant disease. So, it's clearly involving the entire liver, the liver's enlarged, and the bone and nodal metastases are somewhat limited in the total tumor burden. As you pointed out, that node also it also has like lower level uptake with with the Lutathera. I'm not sure if that's like really the major concern, though it is a concern, but the most concerning piece of this is the liver, how to control that liver burden, disease burden. In terms of avidity, I think it's eligible. So like when you look at the MIP, you can see that there is the node seems to be right next to the kidney, and the uptake is above the spleen. Probably the uptake in the spleen is lower because there's such a high disease burden that most of the dotatate is going to the disease. So it is certainly one thing you could consider. And I know that it's unfortunate Dr. Laidlaw couldn't stay on for this, because I think it would have been nice to hear what her thoughts are on an entire liver, directed approach. We have like Y90 to both lobes of the liver has kind of fallen out of favor, because if you're going to do it prior to PRRT, but that was used in the past because you could again achieve shrinkage of the tumors using that approach. And so I know she has done bland embolization to both livers also, depending on the scenario. So I don't want to comment specifically on whether that is an option in this case, but that I think is another component of the discussion we have sometimes, to Dr. Chiorean's point. If it's all in the liver, we may try to do those liver-directed therapies and then spare that additional systemic exposure from the Lutathera for later. But
yeah, this patient did have TACE. She did have transarterial chemo embolization in China, and she had a little less than a year benefit after that. And I think that may have been one consideration why we didn't choose at the time, to go to liver embolization. And also, we estimated that this patient would be a PRRT candidate, and were concerned about Y90 exposure with prior liver with toxicity if we would go to PRRT after Y90.
Yes, yeah, that's always a consideration.
Yeah, and one other thing I want to highlight, and I see Lisa Yen is leaving a lot of questions in here. So Lisa is our head of the Neuroendocrine Cancer Foundation, coming down from the California region, so in LA. And so I think she's asked some very good questions. So I think one is, obviously we've put the TP53. So for those on the event, TP53 is what we call a tumor suppressor protein. So it really tries to prevent, from cancers progressing and developing. And so if you develop mutations in this gene, then it allows, unnecessary DNA replication and leads to further cancer growth. And why this is relevant in neuroendocrine cancers in general is because oftentimes we see these mutations more in a neuroendocrine carcinoma or faster growing type of process. So one that might influence whether the decision has to be upscaled to more, aggressive chemotherapy. So I think that's one consideration here. And then I guess Lisa had a couple of other questions. I think one for Dr. Fogh, and then potentially in terms about for the medical oncology teams. First question to Dr. Fogh, are there any parameters in terms of neutropenia or platelets when you're considering acupuncture? And I guess that has to do with infection bleeding risk. So.
Yes, exactly. So you want to make sure that the patient is seeing a well-trained acupuncturist. Our team actually has a list they put together for over the Washington state, making sure that an acupuncturist has experience working with patients who are receiving therapies that could be suppressing their counts. And the reason is exactly what you stated. Obviously, if platelets are too low, that's a bleeding risk, and we don't want to create an infection risk. And so it's just important that there's an acupuncturist who is well trained in understanding what those parameters are.
Great. And then the other thing is for, I guess, Drs. Iravani and Chiorean, kind of what's your level of concern for bone marrow toxicity, i.e. the risk of myelodysplastic syndrome, MDS, or acute leukemia, given the patients already had alkylating chemotherapy, meaning the temozolomide. So.
Absolutely. We are worried about it, and that's why the medical oncologist will monitor the patient very closely. So we are aware that low rates, less than 2% of leukemia, low rates of myelofibrosis, myelodysplastic syndromes can occur. And I don't know that there is a perfect way to predict who has that risk, but because the risks are still less than 10%, and we would only use, these treatments, of course, upon progression when it's like we don't have a better option. The best we balance out the pluses and the minuses, and in this case, I think the choice was to do PRRT even with a previous preceding exposure it was about a year to CAPTEM. It wasn't long term, years of temozolomide. So I think that this remains a concern, but the immediate concern about more rapid progression was the predominant concern, and therefore PRRT, I think, was recommended in this case.
Yeah, and Dr. Chiorean, thanks for the clarification because I misunderstood that statement about the P53. So to clarify, this is not a mutation in P53. I think this was looking at the protein being made. And so I think it's P53 positive, meaning the protein is being made and it's active. So it is doing its job. So this is actually not a P53 mutated cancer. So hopefully maybe not as bad as like a neuroendocrine carcinoma. So thank you.
Great. And I guess back again, it's a matter of weighing the balances between the how the tumor is going to progress, consider the toxicity. And if the patient have normal counts or near normal counts, I think we would continue with the PRRT and closely monitor the PRRT because we don't have a very reliable predictor of which patient may develop MDS or AML currently. There are some tests like clonal hematopoiesis that we could do, but these are kind of risk stratifying, and it is in the context of patients kind of informed decision with the patient that there might be increased risk compared to normal population, but then obviously the risk of disease progression is much higher. And so the patients, basically the multidisciplinary team decided to give the patient PRRT. And as I mentioned in the last case presentations, that we do post-treatment imaging 24 hours after each cycle of treatment. And we use this SPECT imaging, which is almost similar to the PET as we see, the first cycle as the baseline and the subsequent cycles to monitor the response to treatment. And particularly is very important in patients with the higher grade disease like G3, when we actually see the changes. So I leave it to Dr. Chen to interpret the images for us.
I don't know. I think Dr. Iravani, you're the expert in terms of, even though I know we both look at these. But clearly they've had a marked response. I think this is really nicely showing, kind of similar to that other case, the initial response, the bone metastases all seem to respond really well. There's a marked loss in the lutetium dotatate uptake at those sites. And additionally, in the liver, like a lot of those liver lesions have stopped taking up the lutetium dotatate. And at least subjectively, this is where I'd want to look at the cross-sectional imaging. It looks like the liver might be a little smaller. It doesn't extend. Oh, thank you. Yeah, it doesn't extend so far to the left side of the abdomen like it did before. As you can see, like on that initial study, the liver is almost taking up the entire upper abdomen, and now by the fourth cycle, it's actually pulled back a little bit and is not touching that very left lateral side of the rib cage. So this looks like a really encouraging response.
One thing that I wasn't quite well shown on this big and MIP images is it's easier to see on the transaxial images that I want to kind of bring attention to as well. Yeah, so there was this bone lesion.
Oh yeah, I think that was hidden like below the liver there, that's progressing. Yeah, because the sclerosis is increasing. And I did want to comment now that we have those up here too. So definitely that bone lesion is a little concerning for a resistant site to, even though it's taking up the dotatate. But then you'd want to look at the liver too, because you can end up getting the like dotatate negative disease potentially can emerge also. I feel like we don't see that as often, but you can definitely see sites that have lost their ability to take up the lutetium dotatate, but then they're increasing, so their phenotype has changed. And so that's where the anatomic imaging is really helpful. But yeah, that's unfortunate. Yeah, so that and I guess it sounds like that was symptomatic then.
Right.
The progression.
Yeah, so in terms of this imaging, so her Lutathera occurred, cycle 1 was in October 2024, and the last one, the fourth, was in May of 2025. So the images here, Dr. Iravani, to the right, do we have is this the last SPECT after cycle 4, or when was this taken?
Yeah, this is the SPECT at cycle 4.
Got it. Okay. So we see here that the lumbar spine clearly is peaking in uptake. Sometimes, oncologists think that increased sclerosis denotes actually healing, because sometimes bone lesions are initially lytic or show weak bone, very frail bone with a risk of rupture and fracture. And when the bone heals, it becomes more sclerotic. And I have to say, I have seen the patient in June of 2025, a month after completion of Lutathera, and she was actually feeling wonderful. She wanted to go back to China, and she was ready to go back to China for a visit in July or so. So we were, again, even with increased sclerosis, it wasn't clear that is a progression versus is just a marker of treatment effect in the bone. Sufficient to say that, as you see here, by August, she developed increasing low back pain and clinical deterioration.
Yes, so this is a longer term follow-up. So on the left side, we have the pre-treatment or pre-PRRT dotatate PET scan. And on the right side, we have about 6 months after completion of PRRT. So the images on the prior one was the last cycle, and this is 6 months after the last cycle. And again, Dr. Chen, if you can comment on.
So it looks like actually where it progressed, because I'm guessing that what's causing that low back pain is that really avid lesion in the lower lumbar spine that's on the transaxial image at the bottom of the two columns of the transaxial images. It's on the bottom right. So that is actually not the same site as where we were seeing that increasing sclerotic lesion.
Yeah, this is the one
that was higher up. Yeah.
Higher up. It's kind of
hiding
behind the liver.
Okay, thanks.
Yes.
Okay, yeah, thank you.
So it makes a lot of sense. So her symptoms were actually in a different spot altogether.
So I do think that, well, thank you for helping me orient where we are in the sclerosis actually in that particular lesion. So that's actually at the level of the liver. So that was the one that was showing uptake on the SPECT. Is that correct, Amir?
Not this one.
Yeah, not that one.
Not that one.
The one higher up.
Higher up.
Yeah. Okay.
So I wanted to point out that the patient was never symptomatic in the higher lesion. Her symptoms developed. There were new symptoms in the lower back. that occurred about August, September, which is about 3 to 4 months after PRRT. And the scan to the right, what we see is December of 2025. So by now, if I interpret this imaging scan correctly, we see actually some new lesions that have developed. Some of them appear a little bit new even in the liver. New lesions occurring in the liver, new lesions in the bones, which were not there before, suggesting potentially even new clones of disease developing.
Right. And one of the things I want to mention as well that if we look at the liver in this patient, we may think that the disease did not respond to PRRT, but in fact it did. And this is basically what we need to compare. In fact, is the post last cycle SPECT PRRT as the new baseline to the recent PET scan that's 6 months after. So the patient had quite a response in the liver, but then within 6 months, again, as was kind of expected with the grade of disease, kind of progressed.
She progressed outside. There is a question about continuing somatostatin analogs, and there had been studies suggesting that with Lutathera, people that continue somatostatin analog during Lutathera and after have better outcomes comparing with patients who don't do somatostatin analog. So yes, it is recommended that patients continue somatostatin analogs after treatments with Lutathera.
And, so a slight follow-up. So at this time point, Dr. Chiorean decided to do the re-biopsy because the patients had another progression. And this time, again, like every time that the patient had biopsy, the Ki67 was even higher at 50%. So what are the options? I think there was a question, do we consider re-PRRT in this patient, or what other options the patient had?
Absolutely. And this is a very important question and always discussing with a patient. We want to always see a prolonged benefit from PRRT. And I don't know, Dr. Zhen can speak to if we actually have guidelines, since it's not an FDA approved indication to repeat PRRT after you've already done one. So we don't have like, okay, you can repeat, but you must wait a year, you must wait 2 years. Having said that, common sense tells us that if a patient had progressive symptoms within 3 months after completing a PRRT, my first choice wouldn't be to repeat the PRRT immediately. I think that we have to document, did the cancer become much more aggressive? Did it become a neuroendocrine carcinomas? And we generally look at Ki67 indexes of 55% and above, or poorly differentiated tumors. Luckily, the tumor appeared to stay well differentiated and it maintained somatostatin uptake on imaging. And given the recent data that we had from the cabinet study using a anti-angiogenic agent, cabozantinib, we decided with a patient to give cabozantinib a try. She actually started cabozantinib early January of 2026. Within 2 weeks from starting cabozantinib, she felt better. Her upper abdominal pain, her fatigue has actually improved. We do use generally a lower dose cabozantinib than the standard of care. The standard of care is 60 milligrams. In the cabinet study, almost more than half the patients had to have dose reductions of cabozantinib from 60 milligrams to 40 milligrams to be able to tolerate. Tolerate meaning mostly for fatigue, hypertension, liver function abnormalities. So the patient has been on cabozantinib now for a month and a half with significant symptom improvement within 2 weeks from starting. She also had received radiation therapy to her lumbar spine, to that active lesion that we observed on the DOTA PET scan, and that pain has improved. She still requires pain medications for support, but she's only taking long-acting pain medication. She doesn't need anything throughout the day and feeling overall much better.
Wonderful.
Great. And before we move on too much, I I think there's a couple of questions that might be directed a little bit towards Dr. Iravani and Dr. Chen. Lisa Yen asked if she travels to China, what does she need to know about traveling post PRT and continuing SSA during her travels? And I guess Dr. Kieran can weigh in on that.
Yeah, she actually, because she's been well established in China with doctors there, she has been able to actually use somatostatin analogs in China. And in fact, she even studied the denosumab, bone strengthening medication, in China for her bone metastases.
And Dr. Iravani and Chen, what about travel precautions or travel, things to consider? So,
Right. I guess the post PRRT, we suggest patients to because of the patient could be radioactive up to several weeks after treatments, up to like even 3 months. So we give the patient a card that the patient receive PRRT. So at the airport, when they have kind of more sensitive radiation detectors, the patient can actually pass the custom. And particularly is important when they come back to US because the US has apparently more sensitive radiation detectors. So that would kind of hopefully relieve a lot of issues that the patient may have the delay. We would also, if the patient's in a kind of a shortly after PRRT wants to travel, we might make sure that the patient will have safety bloods and other things at least at their center. If they could send it to us, or it could be checked by their local physicians.
great. And there was a question about what does the finding of extensive necrosis, which I'm going to read in between the lines, not only what does that literally mean, but also how that might mean in terms of tumor biology, I guess. So
I'll leave it to Dr. Chiorean.
It just means that there had been extensive damage done into the tumor. Sometimes, if a tumor has never been treated before, necrosis may mean it's a more aggressive a tumor type, but a tumor that has been previously exposed to PRRT may simply mean that the necrosis is a result of treatment.
great.
I think we're at time, right?
Well, we're actually starting we are at time. So yeah.
We are at time. I think this case basically, I think for me was kind of illustration of how longitudinal care is important and how this patient is going through treatment after treatment and how survivorship as well is important to. This is a almost 20-year history of various treatments.
Absolutely, absolutely. And it's so encouraging to see that during this time we actually had new treatments being approved, so many treatments being approved. And we're going to hear from Dr. Zhen, we have a lot of research ongoing in neuroendocrine tumors, novel PRRT treatments, novel targeted therapy treatments. There is a lot of hope, a lot of hope for neuroendocrine cancers.
Great. Thank you so much for that great discussion, Dr. Iravani, Chiorean, and Fogh, for being here and for your time. So with that, we'll conclude the second tumor board, and I think we're just right on time. So I will go ahead and start the next session, which is the Evolving Therapies and Clinical Trials. So let me go ahead and share my screen. All right. So it's a lot to talk about in 10 minutes about, kind of evolving therapies and that's, and what I'll put my disclaimer, it is impossible to go over everything in the field. Really, my objective in the next 10 minutes is talked at the high level things that I think are going to be in the coming next couple of years or few years that might be potentially practice changing. And so really focusing on those kind of studies. So I think for it, I'm going to highlight some big studies, both for neuroendocrine tumors, right, and then also for neuroendocrine carcinomas, which, as we've talked about, are treated very differently. So for neuroendocrine tumors, as Dr. Chiorean mentioned, this is kind of a general timeline in terms of the various treatments we've had over the years. So, back in the 1980s, we had octreotide as a somatostatin analog. That was one of our first treatments. Streptozotocin as a chemotherapy that was effective in pancreatic neuroendocrine tumors, but that really got replaced when Cape-Tem came out because temozolomide works kind of similarly in terms of like streptozotocin, but better tolerated. And then we had another SSA, lanreotide, everolimus came about. Many of you know about telotrestat, which the common name, brand name is Zermelo, which helped with carcinoid syndrome diarrhea that wasn't being responsive to somatostatin analogs. And then in 2018, we had our FDA approval of our first radioligand or PRRT therapy with Lutathera. Mainly that was studied in slower growing grade 1, grade 2 small intestinal neuroendocrine tumors. We also had CAPTEM come out at that point. And then we really didn't have anything for quite a few years until now. Just recently, we've had cabozantinib, which we'll kind of go over quickly with that. And then also understanding, could we use Lutathera also for patients with faster growing disease and other neuroendocrine tumors in the GI tract? And that was the NETTER-2 study, which we've kind of talked about. So this is a high-level overview of kind of where we come. But I think part of this, in terms of how we're going to advance the field, right? These are all treatments that we do for patients with advanced disease, where again, the goal is really trying to slow down the growth and such like that. But one thing that we've been discussing, and we initially during our talk talked about locally advanced disease, and essentially, we know surgery is important. And for many patients, if they have very slow growing disease, surgery is often enough to get rid of cancers. But the question always comes back is we know that some patients are going to be at risk or even higher risk of a recurrence. And obviously, we want to try to do things to see if we could improve outcomes for these patients. And unfortunately, we have no treatments, right? None of the treatments that we actually have actually can kill off cells. They at best probably control cells. And so we haven't really had any treatments that unlike other cancers, where we can give a treatment and try to improve outcomes. But this study, I think, is a very important study that's being run nationally. It's a study supported by the National Cancer Institute, the NCI. This is a study led by Dr. Suarez, who many of you may know is a national leader in NETs. He's over at the University of Utah. And this is being led by a champion in surgery, Dr. Ahmad, and then also Dr. Washington, who's a pathologist. But this is SWOG is 2104. So SWOG is just a group that is part of the National Cancer Institute to develop kind of clinical trials to try to answer relevant questions. And so this is a trial where really we're looking for patients who are at high risk of recurrence, focusing on pancreatic neuroendocrine tumors. And the reason being is because in pancreatic neuroendocrine tumors, we know, as we've talked about, chemotherapy, specifically capecitabine and temozolomide, are pretty effective for this type of neuroendocrine tumor. So this is actually asking a very reasonable question in patients who are at high risk, defined based on a clinical score. If we randomize them to either giving them 4 months of capecitabine temozolomide after they've had a definitive surgery versus observing, which is our current standard of care, could we try to improve cure rate? So this study is ongoing, been accruing well, so hopefully that will get some results in the coming years. And then I think in terms of other treatments for patients with basically advanced disease, what's on the block, right? So we've had lanreotide, we've had octreotide for a long period of time, but these are all injections that we have to give in the butt. So intramuscular injections, which can be pretty painful, bringing patients into clinic and such like that. And so I think one is the next generation in terms of somatostatin analogs about what are things that might be more potent and easier to deliver. So one of these is an ongoing trial, Sorrento, which I think has already completed accrual. We're hoping an initial readout may be coming up in some conferences as this year, but this is looking at a drug called CAM2029, which essentially is a new subcutaneous form. So instead of going deep into the muscle, this is just like going into the fat tissue. So it's this equivalent of somebody who might have diabetes and doing an insulin injection, just a simple injection into the abdomen. But also there was data that how they designed this drug is actually could be more potent than potentially octreotide and lanreotide. So it might even be better in terms of tumor growth, controlling tumor growth, and also symptom control. So this study, a very important study, and we'll read the readout. And then we also have this drug called paltusotine, which is an oral investigational somatostatin analog. It's actually already approved to treat other conditions that are not neuroendocrine tumors called acromegaly, where patients get really abnormal growth and stuff. But the way that it works is really to help also impacts the somatostatin receptor. And this has been demonstrated in early studies of helping carcinoid syndrome related symptoms. And so there's an ongoing phase 3 study, so a large study comparing to kind of our current standard of care with somatostatin analogs called the CareFinder study, which really is trying to gear towards can it help in terms of controlling symptoms related to carcinoid syndrome, but also they have a secondary analysis where they're trying to understand can it help with tumor growth. So hopefully we might have these new formulations that makes it easier on patients. And then, as Dr. Chiorean had mentioned, we have the new treatment option of cabozantinib. which is an angiogenesis inhibitor. So angiogenesis meaning blood vessel formation to the tumor. So these drugs really try to, inhibit that blood vessel formation of the tumor, inhibit tumor growth. And this was a study also supported by the National Cancer Institute, developed by another group called Alliance. And really, this was first of its kind after patients have gone through many therapies. Most of these patients have already had somatostatin analogs, Lutathera, other systemic treatments. And really, once we get to that point, we didn't really have a lot of great options. And so this was trying to understand, could cabozantinib be beneficial? And the long story short is this was a positive study where it demonstrated that compared to placebo, because at that period of time we didn't have really any other effective options. So here was considered appropriate to patients give placebo. And it's very clear that, compared to placebo, that cabozantinib had a very significant benefit, whether you had a pancreatic neuroendocrine tumor or something outside. And this is not just for GI. This was also included patients with lung, which is very important because lung neuroendocrine patients often get excluded from many of the trials. So this was a very good initiative in terms of including other types of neuroendocrine tumors. And so obviously this has become a FDA-approved treatment as of last year. And so we are already using it in the clinic. Now, the one thing, and I think I kind of skipped out of order, so I'll come back to that, is even though cabozantinib is an effective treatment option, it does have its own side effects, as Dr. Chiorean had mentioned. But the other thing about it is instead of waiting until patients have received multiple prior treatments where treatments may not be as effective, could we consider using an earlier line settings? And so we're looking forward to this study looking at a drug called zanzalintinib, another oral pill. It's similar to cabozantinib, but it's the next generation drug, hoping to be more potent and potentially better tolerated. And this is a trial that is ongoing, and it's really looking at patients in earlier lines of treatment, mainly up to one prior line. So if you're newly diagnosed, you can use it. If you've only had one prior treatment, you can use it. And so this is looking at an earlier line. And again, this is not just for GI neuroendocrine tumors. This is also for lung neuroendocrine tumors as well, where we've had limited trials. And this is a study that we also just recently opened here at the Hutch. And so, and I think this will be a very important study and we'll rate results from. I'm going to go back because this now changes in terms of our PRRT discussion, what's involving kind of in the field of PRRT. So as we mentioned, we've keep talking about retreatment, right? So standard treatment with Lutathera is 4 doses of Lutathera. If you respond, you observe, right? But then the question is, can we retreat meaning 2 doses, right? And a lot of the data that we have so far suggests that the patients who at least have had control to initiate 4 doses for at least 1 year are the ones who are more likely to benefit. We have been doing this as kind of like quote unquote standard of care. However, it is based on no absolute long-term follow-up trial. And so this trial is a very important study. It's led by Dr. Chauhan, who was at the University of Miami and now is at UCSF, but national leader within the neuroendocrine field. And he's working along with Dr. Singh from our Canadian group, really trying to answer this question that is retreatment with Lutathera actually beneficial compared to just doing our other standard treatments? So this is an ongoing study and it's accruing much better now, and hopefully we'll have some results to see if what we're doing kind of in clinical practice actually pans out. Now, in terms of where PRRT is going, right, there's a lot of changes here. Lutathera is basically, and again, I really am sorry to Drs. Chen and Iravani if I'm explaining this incorrectly because they're much more experts in explaining this, but this has to come down to basically looking at radiation particles and goes back to physics. You can use different size particles. And so Lutathera is based on beta particles. So when beta particles, what they do is that essentially they can get through the cell and your DNA is in the middle, right? And DNA is your blueprints to allow the cells to copy and regenerate themselves. At best, beta radiation probably damages 1 of your 2 strands of DNA. So you get 1 from mom, 1 from dad. And so if you damage 1 of the 2, that's often enough to kill the cell, but sometimes it's not enough, and that allows the cell to replicate. And so we have next generation radioligand PRRT therapies called alpha emitter therapies, where smaller particles able to be to get to the nucleus where the DNA is located, and a higher chance of potentially causing double-stranded DNA breaks and becoming potentially more potent. And there's been many early phase studies suggesting this could be beneficial not only patients who've gotten beta emitter PRRT like Lutathera, but could also be more potent if we actually use it as an upfront treatment. And so along this lines, this is a very rapidly evolving field. Of the many alpha emitters, these are kind of the three main ones that are kind of being investigated, and they're all designed differently based on what radioactive molecule you're using, right? So this is all based on when you go back and you learn the periodic elements and everything like that, is what radioactive element are you using? So we have actinium-225 dotatate, there's lead-222 dotatate, and then this one is another lead drug, which is designed quite differently because here it's basically a drug which has two different type of radioisotopes of lead. And the idea is one is really using it as a kind of diagnostic imaging marker because I think our current scans, it's a little bit difficult to detect. And then the other, the 212, is the actual agent that actually is going to kill the tumor cell. And so I think here, actinium-225 dotatate is probably the farthest along. That's just based on the Action 1 study. So this is in patients who've received prior Lutathera in the past, had control, and then their cancers grow. And now we're trying to see if the actinium-225 can become another active agent. And so this is a study that has been ongoing. It's already closed to accrual. However, there is one part of the study where the FDA right now wants more data about how the drug is processed in the body. And so this is what we call PK pharmacokinetics, where we collect blood and urine samples to kind of see how the drug is broken down. And right now we have this study where not every center is able to do this, but we have the ability to do this. And so for select patients who are willing to come for those frequent blood and urine samples, we have this study ongoing. And then with regards to the lead agents, lead dotatate there's been some recent data that has been effective, but there's a unique toxicity, swallowing issues, what we call in medical terminology dysphagia, which I think we'll have to see over the long term. And then we also have this study open of the different lead agent of the lead-212 here that's open. And these are for patients who's never received prior Lutathera. And I think we've had one or a couple of patients who've been enrolled onto the study. And then for neuroendocrine carcinomas, where we're here. And so this is just to remind you, this is a field where I felt like many years ago, no one paid attention to. It's such an aggressive type of cancer. We had very little treatments. The treatment standard has not changed for many years. And really, our treatment standards copied from small cell lung cancer, which is a neuroendocrine cancer of the lung, which often occurs with smokers. But like I said, in extrapulmonary, these are some of my healthiest patients, and there's no reason why they get these cancers. And once you progress on chemotherapy, which is combination of drugs called platinums, and the two ones are cisplatin or carboplatin with etoposide. And then if you progress, we have other options, but they don't all work that great. Now, there was a comment about where is immunotherapy in the field? Well, in terms of the data of what we know about immunotherapy, so nivolumab and ipilimumab are two types of immunotherapy drugs that have already been used in many different types of cancers. But in terms of prior studies of what we've learned, is this the SWOG study, which was another National Cancer Institute study. They looked at it in neuroendocrine tumors. And what you can see here is that essentially green are patients with low-grade disease, patients with high-grade disease. And what we're seeing here is basically a waterfall plot in terms of how patients respond. So if you're above 0, these are tumor growths. If you're below the 0, and especially if you come here, these are patients with tumor shrinkage. If you get all the way to 100%, the tumors go away, right? So basically what this is highlighting that really we're seeing potential responses in patients who with faster growing disease. So the neuroendocrine carcinoma or grade 3 kind of cohort, but not necessarily the slower growing tumors. But with that said, the responses are still pretty low. So in terms of rates of shrinkage, it's about 10 to 20%. And the problem is that we still don't have an idea of which patients are going to be benefiting. So most patients actually do progress on this treatment, but we just don't have good biomarkers to predict who is actually going to respond to this treatment. And so from this, that was a study was done in very refractory patients, but we want to try to see, could we combine it in chemotherapy earlier when patients are newly diagnosed? And so this is a study that I'm co-leading with Dr. Chiorean. This is a study been ongoing. This is also run through National Cancer Institute cooperative group. And this is a study that hopefully will have results, but basically it's trying to ask the question, could we move immunotherapy now in newly diagnosed neuroendocrine carcinoma patients, both in the combination with chemotherapy, but then also could we use the immunotherapy as a chance of controlling the disease for a period longer after we finish the initial course? But then also sometimes immunotherapy can have long-lasting responses, and we may not need to give them more immunotherapy and the potential risk for side effects. So we're also trying to ask the question of, what is the role of doing immunotherapy as a control kind of thing? And so I'm happy to report this study is actually enrolling pretty well, and hopefully you might have results within the next year. And then, we're hoping to also learn from these studies because, like I said, we don't have good clinical factors to decide who might respond to chemo, who might respond to immunotherapy. So this is our opportunity. And we're collaborating with investigators down from MD Anderson to kind of, from all the tissue collected from these studies, to better understand predictors of response to chemo and immunotherapy. And then in terms of novel therapies for neuroendocrine carcinomas, so I'm going to give a high level. It's impossible to review everything, but I kind of want to touch base on the big things. But the next generation drugs that we're going to be thinking about are what we call bispecific T-cell engagers. So basically the idea is that it's an antibody. So antibodies recognize something and block something. But here what you're trying to do is you're going to recognize something on the tumor, and then the other part of the drug actually recognizes something on your T cells. So your T cells are your immune cells that can not only be helpful for fighting viruses, infections, but also very helpful for fighting cancers. So if you bring a T cell close to a tumor, potentially you can fight cancer that way, right? And that's what bispecific T cell engagers are. The other concept is also antibody drug conjugates. So again, taking the antibody, you recognize something on the tumor, but instead of just blocking the signaling of it, here we're linking the recognition with a chemotherapy. So the idea here is, compared to traditional chemo, where we give it IV, hope that it penetrates in the cell, here you're using it as a targeted way to deliver higher doses of concentrations of chemotherapy directly to the cell. And then here we won't talk a lot because this is very investigational, but it's CAR T cells. So utilizing your own cells, re-engineering them to recognize a tumor target and fighting cancer that way. So there's a lot of different trials that are looking at these various approaches. But one approach that I want to talk about that I think is going to change potential standard care in the coming years is a target called DLL3 or death-like ligand 3. This is involved in a pathway called Notch, which basically allows cancer cells to grow. But here, this is a bispecific T cell engager. So here we're just using the DLL3 as a target, and then we're bringing into T cells, which is the other part of the molecule, and try to activate the immune system to actually attack the cancer. So there's two drugs that are now available. One is called tarlatamab. That is approved in small cell lung cancer, not though for extrapulmonary neuroendocrine carcinomas. There are some initial data that when we looked at prostate neuroendocrine carcinomas that there might be responses, but then there's another drug called obrixtamig, which is actually in active investigation, very much many studies looking at extrapulmonary neuroendocrine carcinomas. And what we learned that in patients who had very heavily pretreated disease, the DLO3, meaning the amount of protein that's expressed on the surface of the cell, doesn't matter compared to small cell lung cancer, where it doesn't really matter as much, just because most of those patients do have high DLO3 expression. But here in extrapulmonary neurons, it looks like we do have to test. And so many of the patients, that's why we're testing for DLO3 to see if we can get them into studies and everything. But this drug is moving along very nicely. We're hoping to see some data in patients who've received prior treatments. But Fred Hutch, we're actually going to be opening the first line study. So basically in patients who are newly diagnosed, we're going to combine it with that carboplatin and etoposide to see if we can improve the responses. And then just in a kind of a idea of antibody drug conjugates. So this is, again, an antibody recognizing a protein, but now we're delivering chemotherapy directly to the cancer cells. One interesting target is SEZ6. So this is just another protein that we can see expressed on neuroendocrine carcinomas. And this is an antibody drug conjugate that basically delivers chemotherapy to the cell. And here was some preliminary data of this agent demonstrating some very nice responses. So if you can see all these bars that's falling below, these are patients who are getting tumor shrinkage, even some patients who are getting complete tumor shrinkage. So, and more to come. This is not the only drug, not the only target, but just to give you an idea of what's to come and more to evolve. And I think what's exciting is, like I said, many companies previously never committed resources to understanding neuroendocrine carcinomas, but now many trials are starting to develop drugs for this disease. So really great. So, and that's all I have. So.
By the way, I thought you did a great job. explaining the
Thank you.
the emitter therapies. So.
All right. I know Dr. Chiorean's been doing my part for the medical oncology, answering questions. So, all right.
There had been a few questions about how long does it take? And Dave, please chime in on this. You know, we see some extremely exciting research. When do we expect some of these drugs to make it to the market, to make it in the clinical arena that are currently in clinical trial? And specifically, there was a question about the Sorrento drug. When do you think that that will be available in practice?
Yeah, I actually met with the company who produces the drug at one of our recent national meetings, and they had told me that they're actually hoping that maybe they might be able to present results later this summer. So that's the hope. We'll see. Obviously, the big things about when we want to present results is that we need to make sure the results are mature. And obviously, neuroendocrine patients, they live a long time. So if you're going to really kind of want to see a benefit, you kind of have to wait a little bit and be patient, right, to see how the results pan out. So, but hopefully we'll have some preliminary results. And then as Dr. Chiorean mentioned, even if the results are positive, it has to get reviewed by regulatory authorities like the FDA. They have to review everything before they put a label on it. And once the label is on it, then that gives us access to the drugs to use in clinic. So. Somebody asked about rituximab. Well, rituximab, what this drug is an anti-CD20 antibody. So basically, CD20 is one of these markers that we can see on immune cells, specifically our B cells, which make antibodies, right? The rituximab is mainly used in blood cancers like lymphoma, where we know that target is present. In terms of neuroendocrine tumors, maybe there's some tumors that might make CD20, but I'm not sure CD20 is a big major target that we're seeing as a relevant in neuroendocrine tumors.
Yeah, I agree, Dave. I don't think I've seen any research with CD20 for neuroendocrine.
All right. Well, I'm just giving a couple minutes to see if there's any last minute questions that come through the chat. But I want to thank everyone for joining. So number one, thank you to all the panelists and all speakers. I know how busy you are. So thank you for taking the time, coming and doing this event. I want to thank Denny and Gary from the patient advocacy groups for basically supporting the Hutch and also supporting this ongoing program and stuff. And we're planning on continuing this every other year. And then I also want to thank Alana for all her efforts in helping to organize this conference. Again, would not be possible without her help. And thank you for all the participants. I know it's a Saturday morning. You rather prefer to be doing other things. It's Valentine's Day. You want to be with your significant others. So, so with all of that, I really want to thank you very much for all joining. And with that, we will conclude our event. So.